This conference will now be recorded.
Dr. Safia,
Yes.
we can hear you.
Right, okay, thank you. Okay, so rather extensive session today because we will be covering a lot of topics, important one from clinical governance point of view. But do not worry, everybody will receive the recording of this. So if some of you are busy, they need to do other things, feel free to go and do the stuff in between. You will have the recording anyway, so don't feel bounded. But obviously, if you're not doing something more important than preparing for the exam, then please stay here. Okay, so we said we will start with the clinical audit in reference to the couple of recalls which usually appear in the exam. Yeah, so two sides there. So just for the introduction, most of you have had the recording already and you have gone through it. So just to simplify, so what is clinical audit and why we need to do it? Just simpler, in very simple words, is quality improved process. Okay, we do that at regular intervals about all the aspects of our practice, and again, not only for the clinical practice, but sometimes even for other things as well, like if there are patient complaints coming too much. Again, you know, go back, if I refer back to our maternity dashboard, these are the few things which actually go side by side. Yeah, so all these type of things as well, which we keep record here on the maternity dashboard as well, like do we have appropriate staff, do we have because if we want to ensure safe delivery of safe care and also high quality care, then we have to obviously keep an eye on all the aspects of that service framework, right? So the audits will be done if we feel we are short of staff, or what are the problems, you know, why we're not getting, why we're short of price. It's just like we have equal, you know, we have recruited all the posts which we needed, but what's happening? Are most of the people going off sick? Or is of a shift pattern which is not working quite right? Is it like some personal staff preferences that most of them want to work in the night or in the day, and that's why we don't have equal staff in shifts? So all these type of things. So that aspect then about the equipment point of view, if there is, you know, something goes wrong with it, or we don't have appropriate equipment, what's happening? Are we not ordering the required number? Or if we're ordering, are we wasting them? Are they becoming faulty or what? Yeah, so all that, where basically any aspect where we need to look into and understand what is the reason of this happening, what's going on, that is called audit. Okay, so number of staff, it can be about the workforce, it can be about our clinical practice, manager of shoulder dystocia, cesarean section, all aspects. There are standards given to us by our RCOG and by NICE guidelines. So instead of individuals as making their own ways to treat, and obviously that's going to be then severely compromise the standard of the care. There is a kind of, you can say, a central regulatory system which give us clear, you know, the standards and the guidelines, which itself has come from a lot of, you know, data analysis and the evidence. It's not they just give some numbers and ask us to do miracles and meet these numbers. Okay. So yes, it will be about our clinical outcomes. It can be about, and it doesn't necessarily have the things to go wrong. We do sometimes just, we feel everything is going all right, but still we try to mirror our practice here and there, or if new guideline has maybe come out. Yeah. And for that reason, we want to say, that are we adopting that guideline? Have we adopted according to that? What are our outcomes? And sometimes we feel, well, for a long time, we haven't actually done the audit on our breach deliveries to see how we're doing. So yes, maybe we're still falling between these green numbers. But that doesn't necessarily mean we might be just hitting to the high number. And then again, yes, we are able to do the breach delivery number under care, but are those breach deliveries being managed according to the good standards? Because that only gives us a number, yeah? So that's why I said, like, the other sources from where we identify we should do the audit can be sometimes, you know, our risk incidence reports. Maternal and neonatal morbidity is another place as well. Like if you say there are so many, deaths, what's happening. So that is an identification as well. So DATEX means incidence forms, yeah, which we report is incidence reporting. So yeah, so that's, oops, don't play with that. So right. So here we identify, right? So there will be a couple of examples we will be talking about because they have been appearing in the exam. So one of them is cesarean section rate, and the other one is about shoulder dystocia. Okay, so if you look here, cesarean section rate, we did talk about maternal dashboard last time in detail. So the 23 is ideal number, we should say. This is the expected rate of cesarean section in different units of UK. We are expected to stay. It should not go no way above than 25%. And if it's gone, then we must take immediate actions quickly to say what has gone wrong, why we are touching that much higher. And for the simple reasons, because obviously we do know cesarean section have a high risk of obviously morbidity, mortality, another lot of complications. And that's why they need to stay within that range, ideally below 23%. But above 25 means we need to jump. And when we are about 23, between 23 to 25%, as you can see here, that means we should really, I won't just jump only one number of red. We'll be, looking even my single number of orange as well. But if I have got the orange next month again, I will be kind of jumping same way as for the red. Okay, so these are the warning means do something about it. It shouldn't come in there. So that's what are the different measures of the process we check to make sure we are, yeah, okay, so it's a quality improvement process which assesses the quality, effectiveness and safety of particular aspect of healthcare. Yeah, so it can be clinical, like management of shoulder dystocia, as I said, like it can be others aspects of the service as well, workforce, all other things. Complaints and all that. But sometimes it just is simple, like the people can't get the appointments pretty soon. People can't find out, or the waiting time is too long. And there are a lot of complaints coming through, or maybe the GPs are finding difficult and they write letters to us. And in that case as well, we do the audit first to find out like what is the delay actually, how much delay is happening, how long is the waiting list before actually we offer them the. So the audit is a process basically to identify the problem, what is, then trying to review those, whatever the data we have. Obviously, in case of clinical activity, this will be patient's note. In case, say, for example, as I saw, like long waiting time, that will be like all compiling when the referrals came in and when they had the appointments. So there's to analyze the data. And then the next step is to understand why that happened. Yeah, why, if we are not meeting or this problem is happening, why that is happening, are we short of staff, we have less consultants or whatever number of outpatient clinics. And then next one is then to, if we have identified them, they just simply make sense. We need to do some recommendations and do something about it to improve it, yeah? So the next step of the audit cycle is then to give recommendations, right? So identify a problem, define a golden standard. So what we classify will, you say to me that, this particular trust waiting time is too long. For some GP, maybe if they have referred patient to me, they expect that I must see them within 4 weeks or 3 weeks time. And even after 3 weeks, if we haven't seen the patient complained to them and they start writing to us, well, your waiting time is too long. So no, this is not the way to do it. There is again national standard defined, some guidance somewhere to say this much is acceptable. If you go beyond it, then you need to do something about it, yeah? So in our clinical area, in our clinical management, we will be seeing what the gold standards are. And for our clinical practice, obviously, we do understand there are CG NICE guidelines we need to look into. Are we actually managing our patients according to those guidelines? Yeah. And then the next one is data collection, which I have just, clear that we need to actually review whatever that is. If it's about a clinical activity, like say cesarean section, then we need to review all those notes to see what were the reasons, what was the indications, for those patients to have the cesarean section? Who took the decision? Could it be, converted to instrumental delivery? What was the reason if it wasn't? Was those people now, maybe new ST5s and registrars who were in the night? They're not confident to, try the instrumental delivery in theater, and that's what they thought, let's go direct to theater and operate, cesarean or whatever. So this is like, in the data collection analysis of data, that's what we are doing. And then recommend the changes. So if we have understood them, well, these probably are the few reasons, then we need to say that we could improve this, right? So from, all these things which you are ready to say, like involve the consultants in decision making, that reduces the rate of cesarean section. From where did it come? It would have come from, some audit where they did the data, all these, and they found that actually the women were coming maybe asking for elective cesarean section just because she's like, oh, I can't think of the labor pains and stuff. I would rather go for the, as we see some of our patients saying that. And we did that consultation and we said, okay, we explained them whatever we thought what the risk and pros and cons for both sides. And then then we said, okay, we booked you for, and we didn't say, well, I'm going to go and speak to my consultant. Yeah, so that's the consultant involvement. So there was some thing, we might have taken that from there then actually, and that's where this came into practice now. So that's what we say by recommend changes. And if we think like this is how it should be, these changes are, this is how it should be stopped, then we need to, again, very common sense, then obviously we need to make a pathway to see how we're going to do this, yeah, how it should be. And that's why a major change also came in this country from about 2006 or 2008 time. Prior to that, the consultant could be called from home. After that, mostly consultants who have the new contract, they are actually now supposed to stay on the site. So, I mean, they do have their rooms. I don't know. I mean, some consultants who look very nearby probably still go to their homes. But the reason for that was that if the consultant is on the floor, it just simply makes sense. If the patient is consultant herself is in the floor, although she's in her room, she will be also worried about in between to come down and see, what's going on in the labor ward. If it's running very busy, they will come and see the patients. And the registrar or the ST5 and whatever, whoever is on call, they will also be a bit less reluctant to ask for help from the consultant. Yeah. Because calling some consultant at home 3 a.m., you have spoken just 2 a.m. already about one patient, and 3 a.m. there is, I mean, irrespective, we train and we tell them you don't need to worry, that person is also on duty, whatever. But still, there is a natural, a little bit of inhibition to say, I'm really going to, ring the consultant, wake up just for that little thing, maybe I'm fine. I may not need to, right? So these changes, what come in action, they actually have come out of these type of orders and stuff. And then if, say, and that's the other thing, if the consultant is on site and you are ST5, or I'm ST5, and I have this lady, sometimes you're just a bit in, what do I do? What do I do? Did I need to do this? Or, sometimes there are some small little type of confusion. So you're operating, all right? There is a small extension of the data. You're trying to, control, and it's not major hemorrhage that you feel I really need to call the consultant from home. So you're trying to just keep taking stitches and try to control it. But a bit of oozing, just keep going. Now, when you know the consultant is just somewhere in the room on the floor next to you, or maybe upstairs, it's very simple. Yeah, you will ask with midwives, could you please just, call the consultant, just come down and have a look. So it does make a huge difference. So that's what we achieve by doing the audits. And then obviously after we have done those changes and implementing, like we made, yes, say for example, we keep this little example in mind, we ask the consultants to stay on the floor for the night, then do audit after 1 more year time to see what happened. Was that improved though? If our initial one was that, and then again, difficult trial of instrumental delivery in theatre. That ST5 may not be as confident. I mean, it's just below the spine and it's just about +1. She goes, they might be try with the vacuum, bit half-hearted, and it's not coming down, let's go to. But in that case, if the consultant is just in the next room somewhere, or maybe she's already on the floor, seeing some other patient, or she's just upstairs, It's so easy. You know, when I tell to the consultant, well, I think this, you know, it's not delivering. Okay, R is high R. If I'm consultant, you know, I will just say, I will make sure. So station +1 or so it is the head which is +1, it's not capped. It's not this, yeah. And if I know this trainee is the testify is comparatively new or whatever, you know, and I feel, you know, her assessment might be a bit. If I'm sitting obviously in the hospital in some room, a few steps away, I would rather come down and examine the women, see what they're going on. So you know, you can see how that changes things, yeah. So that is about the audit. Very simple. These 6 steps, right? So if you just remember these headings, fit your step between them about any question about the audit, and you've done it. So let's then apply it and see what happens to this one illustration, this recall which appears in the last exam. I could take one of you to actually try this illustration. I don't think this particularly is going to do a lot of benefit, because it's more about the discussion to help you to understand what that is. All right. So I'm just going to go through it. So except that if anybody has come across this station recall, or they know more details, please volunteer the details, tell me, so I can add that. Anybody who knows more detail what else was in this particular scenario. Yes, anybody knows more details to this scenario than what I have written there?
Hello, Dr. Zabeen, Sadia here.
Yes. Yeah.
So this came into my exam. So they basically started with a simple talk of just as it is written as 39% cesarean section rate, and what are your thoughts about this? And then they talk you through the audit process, the governance process, what it should be, who should it be compared with, and everything. How will you conduct the audit? Like, I mean, all the 6 steps of the audit. And then they think that, okay, what do you think? What should you propose? Without talking anything, that what should you propose? What do you think is the cause of increasing number of cesarean section recently? And definitely with maternal requests, they focus slightly more on it. And my answer was that we should, I mean, every patient who requests cesarean section has the right to choose the cesarean section, but she has to decide after the complete knowledge, after the complete counseling with the consultant as well as the birth mattress clinic. So this was their main focus, and the rest they asked about the training and everything, like you already talked. If someone is competent enough to do the instrumental deliveries, difficult instrumental deliveries, how should we decrease the number of cesarean section, emergency cesarean section in that case? So it was through training and simulation courses and the consultant being on floor. So these sorts of things.
Okay, so that was pretty much which we have there. Okay, that's fine. Right, okay, so in this one, basically again then, so when they say, okay, in your department, the rate is so high of 39%, what can you do? So where basically, first of all, we identified we were at 39%, yeah? From where did it come? It came from our maternity dashboard, okay? So it came numbers from here. So we did identify from there, this is going on 39. And obviously the unit might have been going a lot more of these rates before, you know, it can't be 1 month things. It's expressed like kind of, it's like excessive or consistent high number going on of the senior section rate, okay? So first of all, we need to acknowledge here that, you know, the 39% senior section rate is very high. It's well above the standard. So you need to actually refer to the range. Yeah, it should be, you know, the allowed one is that it shouldn't be more than 25%. Or the NICE or the national recommendation is to keep the senior section rate of 25%. And if it goes above than that, then immediate action needs to be taken, which will be in the form of audit and take very immediate. I mean, 39 I saw like is absolutely high, it's extremely high than what we are saying of 25%. And then immediate action need to be taken, and immediate major interventions need to be put in place, because obviously cesarean section is associated with a very high risk of maternal and the fetal morbidity and the mortality as well. In the current pregnancy and also in the future pregnancies. Okay, so first of all, it's important that you acknowledge until it's very high rate and what are the implications, and that it is so urgent, how urgent it is actually to take action about it. So then how are we going to do it? Obviously, we need to, first of all, is that in addition to audit, we basically need to have a team meeting as well. Yeah. So I will say, we will do an immediate audit, clinical audit to run that to try to understand why our cesarean section rate is so high. But at the same time, we would like to have an immediate team meeting as well. Okay. So to discuss that, the possible reasons, the people can also contribute. From the audit, we are going to review the notes and then find out. From the meeting, we are going to listen to the individuals, maybe who are involved in that, all that care. They might bring a lot more information than just from the review of the note. So if it was like about 25, 26%, something like that, then probably we could have just stick to the audit and then take it to the team when we present it as a report. But in this particular high level, we need to have an urgent team meeting as well to discuss these all concerns and also ask for the immediate, what they understand, what is the possible reason why our rate is so high, and to contribute their thoughts and also to give their suggestions as well. So we will take that as well, put them on one side as well, and then we run the audit. So this audit will also need to be taken out very quickly. This audit won't be where we will say, okay, I will complete that audit over 6 months time, because when we do the audit, so let's go to the audit. So after the meeting, your next step will be you will need to run the urgent audit. And everybody else, please switch the mics off. Yeah. So then you will say, so first of all, you will say, and we have defined the gold standard where we said, because the NICE and the national standard says the rate should be 25%. So we did. Mic's off, please. Can somebody identify whose mic is this? Okay. So, okay, yeah, so we identified the problem, which they have already given to us. 39% came from maternity dashboard. We defined the gold standard when we said national standards and the NICE, and these says this should remain below 25%. And obviously, they have also given the guidance to follow how we can keep it below. Now comes the data collection. Okay, so the data collection, we have done two parts here. One, we said, so always say the audit first, so the examiner doesn't confuse thinking you're not thinking of doing the audit, and then say, but we need to call an urgent team meeting as well. So the other one will be, so data collection, know what we're going to do. And then again, it's very important to say that we are going to take a very urgent priority audit of this, okay, given the rate being very high. So and need to be really urgent intervention to put into place. So you will then obviously, the data collection is you're going to then have the people, 2-3 people who will be doing that audit. They will be given dedicated time sessions to complete this audit. And then the data will be collected. So the notes of these all patients who have the cesarean section, whatever the time. So maybe we say we are going to, so again, how we do the data collection, there are 2 ways. Either you need to, so data for data collection, then first of all, you need to define the methodology. How are we going to do it? Are we going to do retrospective, or are we going to do prospective? This one obviously it has to be retrospective. Yeah, that's why we are. So what you need to must about the data one, it must be anonymous. Anonymous means, yes, we are going to have those patients, but when we write our report and we complete our pro forma for the numbers, then there should not be any identifiable date of birth, patient number, or anything at all. Methodology, we must say, and you must say, it will be retrospective audit. Yeah, because obviously we are looking back into those number of cases to see why this number has gone so high. Sample size should also must always be defined as well, and their sample size needs to be decent size as well. Like if you say, okay, I'm going to review 25 cases or 35 cases, no, there's not sufficient you know, the size of the data to really reflect. So there needs to be like about well above 100, sorry, well above 50. So at least, and that depends upon the total size of the unit as well. Yeah. So maybe up to 100 at least in this particular scenario where we have so much. Yeah. So we'll say we'll define the sample size, like I'm going to review 100, you know, retrospect. Now, what 100 cases? Which 100 cases? Are you going to take all those 100 cases from 1 month? Are you going to take that, you know, just you will say to the person who is going to collect these notes, send that in data to you? Are you going to say, just send me? There are two ways when we decide our sample duration. Yeah, so this is next after sample size is the duration, what duration we want to. So there are two ways. Sometimes we just pick up the time. We say, okay, for the last 6 months. Okay, so starting, say we are in September. No, I will say from August backwards, 6 months, whatever that falls into, February to August. Or I will just simply say, I need, you know, 100 cases from December backward, sorry, from August backward. So whatever, wherever she will pick up those 100 cases, she will just stop it and send it to you, right? So sample size and then duration of that sample from where we want to pick it up. And then audit too, that's very important. Then obviously, now when we're saying we need to collect the data, we have to, you know, we have to collect those numbers somewhere. So for that one, you need to make an audit pro forma. And for audit pro forma, that one is important because obviously you need to define the standards as well, what we are going to, you know, look particularly into those rules. We're not going to just sit down and read the stories from there to see what happened and then just whatever we feel. No, we need to pick up certain standards. And those standards will be, so I hope you all are aware of the pro forma. I don't know if I have some, I'm pretty sure all of you know, but just for this, you guys, simple one, I mean, the pro forma will be looking something like that. So you will write down the clinical standards here by saying, say, for example, so we know, now we look at the NICE guideline. What does the NICE guideline actually tell us to reduce the number of cesarean section, yeah? So the NICE guideline say, for example, that says like provide one-to-one support to the woman also reduces the, you know, the number of cesarean section, particularly the one where women go particularly for maternal request. Involvement of the senior clinician of the consultant in decision making, that reduces the number of cesarean section. Okay, so just take those. We said gold standard, we're going to compare it with the gold standard, and we said gold standard is NICE. So from the NICE, simply go to NICE line, pick up those few points, whatever that says. Appropriate documentation. So if the CTGs were pathological, do fetal blood sampling. Yeah, has fetal blood sampling been done? And the next one is, say, for example, if it was appropriate and comes under the, you know, the limits, have we tried instrumental delivery? So you can write down those standards there. So you will be then seeing those specific standards to keep it a standard data again for all the patients. Okay, so this is how you will make your pro forma, and that will be yes and no answers. In that particular patient, so patient one, I see all those particularly in those notes. If they have been done, then yes. If not, then no, right? So this is how your data will be collected. So once you have collected all of that data, then you will be, where are we? Go back to our, okay, so that data all collected, all right? During the data, you need to also keep an eye to see like what has been happening, you know? So if you have ticked for that one, you came and you saw that actually the consultant, it wasn't discussed with the consultant that we're going for this cesarean section, or they did not even try for this the instrumental delivery, then and there you can actually see what happened, why not, right? And you will write down that additional note next to that in that pro forma. What was the reason why that didn't happen? Are fetal blood sampling done? No. So what was the reason? Maybe their gas analyzer was not working, yeah? Or the dilatation was about 4 centimeters. She tried 3-4 times, but she couldn't get the sample. And as a result, they have to go for cesarean section, yeah? So that will now help us to do something about what's wrong with our analyzer. If it's not working, get a new one, yeah? Or we need to give more training to people to do the fetal blood sampling, and particularly in less dilatation, if the trainee herself found or himself found difficult to take the sample, could she call the consultant to do the fetal blood sampling, yeah? So that will go along with that as well. And then after you have done all those 100 pro formas for all the patients, you then do the analysis of that data, okay? So analysis again is done. Obviously, you're going to then compare and find out all those numbers of figures, percentages, pie charts. It can be presented in different ways. So you can then choose who you want to present that data. In simple ways, if you do that, something like that. Now, when we are now going to file our data, then it doesn't make sense for us just to write on these numbers, yeah, without actually doing anything about the rest, just this number. If you write on this number, my service, yes, we did this, you know, we, the consultant was involved in 25% cases, instrumental delivery. In the cases where it was, you know, we could, who are eligible for instrumental delivery, but out of, say, they were out of those, only 30% cases instrumental delivery was applied, tried. And fetal blood sampling, again, in those eligible cases, only 10% was. If you will give me only this number, that's not going to make any sense to me, because I don't know what is expected, where we should have been, how much we should have been able to perform. This is 100%. All of these cases, it should have been done, yeah? So for that reason, you must write on the national standard next to that as well. Okay, so the national standards say, for example, in all eligible cases, fetal blood sampling should be done. We did only in 30% cases. National standard is 100%. So we have not met the outcome. All right. So now, if we are saying that we have done that, compared then, I mean, this one are beautiful numbers, but 39% zero section rate won't have that beautiful number. These all numbers will be falling in 25, 30s number, whatever. Then obviously we have said not met. That doesn't complete the exercise, because we are doing all this exercise to actually find out how can we improve what we need to do. So we need to bring up all those recommendations, which you, when you were doing this initial data collection, you were writing next to this. If their fetal blood sampling was not done, why was that not done? Yeah. So then when you're presenting this report in the team, you will actually bring those, okay, that this was not happening. You will give your findings. Now, look, this is now next going to be the report presentation, and this will happen. So you all, those 3-4 people who were given that task, they did data collection, analysis, recommendations, they thought, and now they have prepared the report. This report now, and this is going to be presenting in the meeting of the clinical governance. And in this particular scenario, where the rate is so high, 39%, we may not be waiting for our routine clinical governance meeting to happen, which is different in different departments. In some departments it's 1 in a month, in some it's once in a 3 months. So you won't be waiting basically that long, 3 months or whatever that time will be, because we need to take urgent actions here, right? So if we have to go out of the program and arrange a meeting, we will be arranging them. And who will be attending those meetings? All the stakeholders. And who are the stakeholders? Obviously, all those people who are involved during the labor and the birth process. So that's your midwife coordinators, that's your all trainees, trainee midwives, consultants, anesthetists, and the pediatricians. Yeah, they are the part of that. So you will be inviting them all to attend that meeting. And when the clinical governance, the people who work here, they do and understand, we do not do any elective work on that day. So the maximum number of people can attend that session. Okay, so say for example, if it's in the morning, then only the emergency, like the labor ward and any emergency situation, which is, so no clinics, no elective, nothing like that. They all will be attending the meeting. So right, so then you present your data. Obviously this is different, this is show the dystocia one, but our clinical standards, for example, if we say stick to them, was the one was we said like the fetal blood sampling should be done in 100% cases. The other we said the involved consultant in the decision making, and the third one was like try instrumental delivery in eligible cases, these 3, and we didn't meet them. And then your finding, what the findings? One, fetal blood sampling was not met because we found in most of the cases our gas analyzer was not working. Another finding can be, you know, the training or you know, was the clinician could not take the blood sample. Yeah, so that comes to the skills, right? First one come to the equipment, second reason comes to the skills. And then or maybe the mother was not comfortable when the procedure was being done. She was not able to stay in that position of what we wanted to, and that was, somebody might have documented that one. And if there was, yeah, that will be another finding. What we can do about it? Obviously explain the women about the procedure, give her one-to-one support, like the partner, or tell her to, you know, keep her calm, and you know, obviously that is a difficult for the women as well to be in that position during the contractions and not move, particularly in smaller dilatations, 4 or 5 centimeters when the sample is being taken. All right, so the recommendations will be all this which we talked just now. If the obviously analyzer is out of the work, then get a new analyzer. More training and skills for the fetal blood sampling collection. Another recommendation will be, if the registrar is not able to take it, then consider to discuss with the consultant, call the consultant. And then if the mother was the reason as well, then your recommendation to maybe a more counseling to the women to do that. So once we have said that we need to buy a new analyzer, we need to arrange new skills, then if we just leave it, we all will listen nice time off from this morning, instead of jumping in our wards here and there and every day. We just sat for 3 hours, listen to this nice meeting, half time sleeping through, let's go home now. If we will finish there, that's what is going to happen. No, we need to give those duties to somebody then, who is going to make sure that we buy the new analyzer, and how quick we need to buy this new analyzer. So say, for example, in 39% cesarean section rate, we need to buy the analyzer just literally next week. Yeah, so the time will be according to that. That's what we are saying, right? So some dedicated person will be given, a couple of people, like maybe midwife coordinator or managers. Usually, obviously, these funding and stuff needs to come from the business manager of that team. So whatever the name of that business manager is, yeah, that needs to be done. And then we said, like, we need more skills for the training. Who is going to do that then? So usually we're saying there are people, there is either educational, a clinical tutor, or from the specialty trainees as well. There is a person who do have these things to arrange these educational meetings and stuff. So we will give that person the responsibility to arrange that meeting and drills or whatever needs to be done, quite urgently on priority basis, just next few weeks and months time. Okay, within few weeks time really. And then about the sport and stuff, that we require, more training of the midwives as well, the trainees as well, and the partners when they come home to tell them as well to support to the women, and when it will be done. Okay, so that time will be given. And then we need to say after that time, which means so there is something next column which says progress. Progress means though somebody but then will need to keep an overall eye later on. And that usually is a clinical audit lead. There is an audit team for each department. So they have a clinical audit lead, and then there is a team. So usually one consultant and then midwife. It can be any coordinator midwife or any other midwife even. And then usually some specialty training and then midwife training, whoever. They are the clinical audit team. But that doesn't mean that they must do every audit themselves. No, it will be done by different people. No, the midwives don't do fetal blood sampling, Sujata. That's the answer to your question. So that team will keep an eye that these things have happened, right? So now you can see how robust system is in place, right? There is no leakage from where the things can slip and then we are same in that routine again. All right, so then we will make sure that has happened. If it's not happening, take appropriate action. If funding is the issue, speak to the business manager, the clinical lead of the team, and all these people. They will make it to happen because it needs to happen. They need to fetch money from wherever, maybe put some other project or some other thing on hold and invest the money here first, if that's what the case is, right? The consultants and blah blah blah, and then we interview those trainees who could not take their blood sample or whatever when we ask them, maybe from the notes or during staff meeting, and if they don't want to volunteer in our immediate team meeting, maybe we ask them, give us your opinion, maybe you can send them in written and we can just sometime in routine audits we won't be speaking to those people. But something like this where this has gone extraordinary to the dangerous range, then we will speak to them, not because we are going to penalize them or we're going to blame them, just to try to understand the reason what happened, why they felt, like what they felt, what was the difficulty in doing fetal blood sampling, or could you consider to call the consultant? Oh, I'm sorry, I didn't know that I could actually call the consultant for this. Yes, you can. And from there, then it came okay, because they were told, well, I thought I called the consultant 3 a.m. from the home to come down and do fetal blood sampling because I can't do it. I mean, when she told the consultant, when she rang and said, I'm not able to take the sample and I'm going for the cesarean section, The consultant, if the consultant would have been some nearby, would have actually come to do that. But yes, if I'm sleeping 30 minutes away in my home, I'm just gonna go. I will also say, yes, that's fine. Okay, go for senior section then, right? So from something like that would have come in the audit. Obviously, I haven't seen the any particular audit on that particular reason. And from there, the major change come up. Let's keep the consultants on the floor and make their life more difficult. Right, that was just a joke. Okay, so that's what happens. And then obviously we need to then do the audit after 1 year again to find out whether we have improved. Yeah, well, we will take it, you know, I'm going to, number one is in the, you know, coming to our specific scenario of the senior section rate of 39%. I won't be sitting to review that in 30. I mean, that will be automatically picked up when I start adding the numbers every month. Is it coming down? Obviously, we're not miraculously going to be from 39 to 25%. It will take time. If we have like identified some reason where we actually can't do, again, 39 is the number, we might actually sometimes, if they go, and then it's not only the cesarean section 39, we also need to see whether there were any complications and what type of complications, morbidities, and those happened. And if there were quite a lot of serious complications, sometimes they may be decision to close the unit for the time being till we get whatever we need to. Maybe we didn't have enough trained staff basically, and that's what this was happening. Then we need to. We cannot compromise patient safety and quality. Okay. So these are the few things you need to keep in mind in addition to your standard routine audit discussion, which we will be talking. Yeah. So yeah, and then very important that we will complete the loop, repeating that after 12 months from the implementation date. Yeah. So you know we give the date to make those changes. Because it's mandatory. It's essential to measure the improvement from addition action. And then when we do the repeat audit, then we will compare how we will be presenting that report. Okay, you will be giving the national standards 300%. Then you will give your previous audit findings as well. Our initial audit last year was this. Now we re-audited after all those changes, and that's improvement we have made, and that's the outcome. That's complete the audit cycle. All right. So this is how you will tell them and conclude them, you know, and for the audit, when it starts, the more of the technical side of these ones, you take an approval. So there are these standard actually performance in every unit they have. You just complete them, name, department, whatever audit title. What are you going to do? Is this a re-audit or is it a first audit? Why are you proposing to conduct this audit? Because, you know, the maternity dashboard, the senior section rate has gone much higher, 39%, much above the standard target of 25%, or maybe just to evaluate standard of our practice against the national standard, new guideline, NICE, blah, blah, blah. Okay, whatever that is, you will just write down. What standards will you be auditing against? Attach the copy of national standard, yeah, relevant standard. So you will put the, you will attach, you know, say NICE guideline, these standards. You just get some idea about those standards. And then the next page is you then give some idea about the time and a bit of methodology as well. Is it going to be retrospective? It is going to be, why you don't want to open the second slide? Anyway, and the top here is like, will there be retrospective study or prospective study, sample size, duration when you want to complete this, yeah? So sample size, length of the time to audit and target completion date. So that is just like self-explanatory performance. Yeah, so once you will start the audit, before you will complete this will go to your audit lead. So say I sign it, audit sponsor mean the people who are going to do the audit collection and everything, that one, and then we will send it to the central audit team that we are running this audit, because this report will be then submitted to them as well. Yeah, because it's not only the unit efficiency, overall the trust as well, performance. They have to also watch their overall performance about all specialties, so they need to have that in their place as well. Yeah, so that's about our 39% audit, what we can do. Yeah, what we can do to bring down the audit rate. So you will say by the audit, and then you can just, you know, briefly go through these steps to say This is ordered collection. This is how I will collect and blah, blah, blah. The next questions come, what are your views about elective cesarean section and maternal request only? So that is a bit quite tricky and dilemma situation. Just 1 second.
What is the answer of what can you do to bring this rate down?
Yeah, so that one is number one. We said that whole process was what we can do to bring this rate down. Yeah, do that audit, urgent team meeting, and then find out what actually is going on. Okay, so urgent audit, urgent team meeting, complete that, identify the reasons, recommendations, then put those required changes in implementation, and if and also additionally, obviously, review if there are any serious complications and we might need to stop doing serious sections for the time being, or even service. I mean, that depends. In this particular case, if there is no major complications and stuff, then we don't need to stop the unit for the time being. So that's that whole audit discussion was about what you can do to bring the rate down. Now, the second one is what are you going to do about the elective cesarean section maternal request? Now, this is really difficult, and this is what you need to say as well, that this is really difficult aspect basically. And these days, this has been one of quite common reasons as well for the cesarean section rate to go up significantly. And then we will say, so when it comes like a mother wants to, she come and want to have a cesarean section, I mean, it is her right. It is her autonomy. We have to respect the autonomy. No, autonomy says that's our body. If she wants to go for a cesarean section, we should be doing the cesarean section, and that's usually we do. That's the most of the time happens. The practitioners will talk to the women, tell these are the advantages, these are the disadvantages. So we try to tell them having cesarean section will be a lot of consequences, but that women who have some XYZ reason for not having cesarean section, she has made the mind already, and that basically the evidence shows at that time, basically when we are trying to convince them by telling them all the consequences and the complications which can happen from, say, restricted cesarean section, that actually doesn't work on them. They're not prepared to listen to them. Okay, so that basically that doesn't help. Then it comes like, okay, so shall we just go for it and do the cesarean section because they're wanting up? Now, being a clinician, yes, our one responsibility is that we do respect their the rate of autonomy. Yeah, they want to do it. That's the scene we must respect. But then we should not forget, being clinicians, we do have another responsibility as well, and that is non-maleficence. And non-maleficence means do not do harm or allow the harm to be caused to the patient through that particular procedure or defect. All right. So yes, she says, well, I'm scared of pain, or I don't want to go there, but we do understand. Yes, we are going to, and that's where we reassure her. We will do what you like to do at the end. But let me just, get some information from you and then explain you things, okay? And that one we do basically for the second part, we want to, because we have the duty to be non-maleficent as well, to stop the harm. We can't, we know intentionally, we can't let that harm happen to the patient or to the baby. Yeah, where that all questions later on come then, right? Why we go to the courts, sometime if they're not taking, mom says, it's my baby, I have HIV, I am not on medication, yes, fine, but I'm going to breastfeed the baby. That should be her autonomy as well. It's her baby. But then no, we go to the court because we know this baby will be harmed. And same way, obviously, in the adult people, we can't go against what they say, but we have the responsibility to make. So basically, the evidence has shown that basically, if we just sit and tell them the start straight away from the disadvantages of their procedure, and then start going to and tell them, and then say they're not asking, that doesn't work. And if you remember all those cases which we have done in our different sessions, when we have done a couple of we have done where the women wanted to go for cesarean section. Like this, she had the one previous cesarean and then bad experience in the vaginal birth and then she wants to go cesarean section again. What we said was like, what I usually advise you guys over there is don't start straight from the disadvantages of the cesarean section, because she's not going to listen to them, and that will also show you as a biased person, because you don't want her to have a cesarean section. Instead, listen to her. Okay, now the women, if they're taking some decision, there are different reasons. If they may have a fear of the pain or something, they may have some traumatic experience, that's why they don't want to go for it. Yeah, or any other reason. They might have experienced traumatic experience with some other family member, and they've got so scared from that they feel if we deliver in the hospital, these doctors are going to do all heroic interventions with us, so I better deliver at home, right? So there are genuine reasons and thoughts in their mind, which we know on our side. Yes, we don't want to just do cesarean sections because we want to, but they don't know it, right? So that's why this is very important. We explore the reasons first, and before the reasons, if I just simply say, would you like to please tell me what happened and why don't you want to, just she will tell the experience. Now that doesn't complete your duty of exploring the reason. The next one is to gain the trust of this woman. Now I must acknowledge, and that acknowledgement again shouldn't be just like a simple sentence to say, oh, I'm sorry, you have to go through this. So, but if you have a cesarean section, this is what is going to happen. No, listen and just say, oh, I'm really sorry, and appear sorry. I'm really sorry that you have gone through such a traumatic experience. You didn't like it. So what happened, like, so I just remind you, I'm going to use the example here where the woman has a first cesarean section because of the breech. Second time she had a vaginal birth and she had a retained placenta. She couldn't get epidural at the right time. And then this time she wants to have a cesarean section again. Yeah, you all know we have done this in the last one. Okay, so I'm just going to take that woman counseling. So we need to basically to her to say, I'm really sorry that happened. Okay, so what happened with the, with the epidural? So I have no hurry to start talking about this cesarean section. I'm going to relate with her first, so she can start trusting on me. And then she started talking to me, and she started believing I will be what I'm saying is actually really in her good interest. Okay, so I will say, okay, so what happened then in the epidural? Why couldn't, oh, I'm sorry. But yes, actually, because I have to tell her the right reasons. I said, yeah, that can happen. And then, so how you been doing after that then, because now I need to explore, is that just the feeling of that moment, or that actually has become a flashback for her? Do I need to send her for counseling? So is that something still bothering you, or what, how you feel about it? And then we'll say, okay, that's fine. So what we can do, how you feel about, we have a, plan and in place this time. Clearly reassure her first by saying, yes, we will do that. Well, let me just have some information from you and give you some information. And then just start from, again, just simple from non-judgmental, maybe start from the good points of cesarean section. But you're right, yes, with the cesarean section, sometimes, yes, there can be a bit of reassurance. There's a planned procedure will happen in there, and, it's done and it's over. However, there are, a lot of complications and risk with that as well. No, she said, I had a first cesarean section, and that will be a very common answer. She has that experience already. I had that one, and that was pretty straightforward. I was able to go home 3 times. Yeah, that's right. The first cesarean section usually is, be careful to use the word but. So yes, I would rather say yes. Yes, the first cesarean section usually is pretty straightforward. There is no other extra complications in here. However, when you have one operation, the tissue heals with a lot of scarring, it leave a lot of adhesions inside, and your bladder bubble, blah, extra, blah, blah, blah. They are right together adhesions that risk, and this is going to be really high risk this time. And then, because of that, scarring your wound and the womb will have the scarring as well, and then the repeated cesarean section, that's going to have another adhesions. And the next time, the risk is that your afterbirth actually, there's a high risk. There's a very high risk that afterbirth actually can attach low, and it can get stuck into that. And then, there can be life-threatening, and sometimes, death. And sometimes, if you can't control the bleeding, we'll have to remove the womb as well. So, how you feel about it now then? And then I come to the, straight away, before saying how you feel about, maybe it's a good idea to say, yeah. And if she asks any questions, again, a very friendly way to say, yeah, this is, like this, and then come to the delivery side and say, So with the delivery, again, start by acknowledging the heart factor, because she will be happy to listen that yes, you understand it, you're not just ignoring it, but saying, yeah, in delivery, you're right. I mean, that is one issue here, that if you're planning obviously to have a good pain relief, and if the anesthetic is not available, then yes, it can be. However, that doesn't happen all the time. Most of the time, the women, when they request to have an epidural, we are able to get them epidural time. But what we could do, maybe this time, if you would like to go ahead with the cesarean, with the vaginal birth, we can have a written plan for your pain relief in place. So we will arrange, we can plan to have your epidural in place quite earlier in the labor, rather than waiting too long. So, you can, in the beginning, you can stay Pethidine, get an air, and then you can have, epidural a bit earlier. We can get the anesthetist in. However, obviously that can't be promised, in case, if it happens again, there is a major emergency, the anesthetist will have to go there. So, I mean, it's really up to you what you would like to do. We will do that. Again, we're just reassuring her, you got the control, but listen to us. And then we can say to her, okay, so that happens. Where you may consider, if you go into, you try for vaginal birth, and if you feel you can't get the epidural or you're not liking, the pain, and that's not being relieved properly, you can still choose to go for a cesarean section. But yes, obviously, in that case, if at that stage you have to go for the cesarean section, which is done during the labor, has slightly more risk of complications than the risk as compared to the planned one. So what I'm doing here is, I'm giving her really the information. I'm helping her to make a decision, but I'm not trying to lie something to say, the vaginal birth is absolutely nothing is going to be wrong there. I'm trying to give her control. Try. If you wouldn't like, you can go, because we know it's very unlikely that if she has the pain relief and everything, then she would still like to go for cesarean section, unless she has developed proper pathological fear. Yeah, in that case, then if she expressed already, she's like, oh no, I don't want to even think about it. I had such a bad experience, I still get the nightmares. I do not want to go into that. Then we can recognize this woman needs. So it's okay, that's all right. We can do, and still give the information and then say, so how you feel about if I arrange your counseling as well, that just, talking to that person and just letting those things to come out, it will be really important, because otherwise long term, so we are not only thinking about this time she goes for elective vaginal birth or not, we need to address, because then she has a general problem there. In that case, then we will arrange the counseling as well, and then we will say, okay, so I'm just going to go now and talk to her. Say she still said, like, she's really terrified and says, no, I just want to go for the cesarean section. Okay, I'm just going to, okay, so I'm going to go and just talk to my consultant and just inform about the decision and see, if she wants to come down and have a word with you as well before we put you on the list. Yeah. So this is how you will do. Do not leave her for next appointment, because the next appointment is difficult to get again quickly soon, just for that reason. So if she needs, we feel it is, I mean, even if she's happy, she has happily agreed. If she has just simply agreed, yes, I want to go for, which, okay, I will say, I'm not sure. In that case, yes, you will say, okay, so what I'm going to do then, I'm going to use the written information about both, like repeated. So this time we're going to give written information about the repeated cesarean section, right? And then the vaginal birth, have a read about this, discuss with your partner, and then let us know. We will plan you accordingly. So, with all this information and everything, if you still feel that you just want to go for a cesarean section, then let us know, because then we will need to plan you for about 39 weeks. Okay, this is how the counseling should happen. But coming back to the discussion, so in this moment, yes, right, so for this, when it says, like, instead of just trying to explain her, the patient or the women, about the risk associated with the cesarean section, and only the advantages of the vagina, but that actually doesn't make much difference to change their opinion. It rather is, the most important thing is that you discuss the way I have told, you acknowledge their the fear, worries, whatever they have, explore them first, ask them what they want, explore a little bit more further, acknowledge, agree with them, yes, that was, it can happen, it happened, I'm sorry, and that's really bad experience you've gone through. And then talk about both, and then also give her the control, give her now what we can do basically to help and facilitate her and try to reduce the risk of the same, whatever the fear complication she saw or she suffered, we can actually help her to reduce down. So that's the one main important reason. The second is, as we said, to involve the consultant in that decision making. And the reason why we want to involve the consultant in decision making is not only because the consultant is going to do, because you are still a trainee. Yeah, so maybe some people are very good in talking and they have the skills and they can, but obviously your experience field is less as compared to the consultant. So their way of counseling, their way of speaking, their way of providing support to the patient may be slightly different than yours. And then there is a psychological effect as well. The patients do feel more confident if something is coming from the consultant because they do believe it's a more experienced doctor. Yeah. So that was the reason why we want to involve the consultant. So address, yes, explore their concerns, acknowledgement, provide them empathy, provide them support, and support means that tell what that support is from the family members, from the support during the labor process, one-to-one support, presence of their partner or any other family member, they feel more supported to be them there. Explanation during the labor process or even what is happening, telling them, counseling them properly, this is what is happening, reassuring them as well. And that's why, again, if you all remember, when I say whenever we tell somebody about the complications of any procedure, we must then and there tell them what we will do to prevent it from happening. Yeah. So the reason to do that is that we are giving them reassurance. This application, but don't worry, these are the things we can do to prevent it. All right. So that's what the answer of your last question. Couple of quick questions before I move to the next one. To the fetal blood sampling, one question we had to know, the midwives do not do fetal blood sampling. The obviously consultant and ST5, your ST3 onward, they are trained to do fetal blood sampling. Even ST2 can do fetal blood sampling. You just need to check with them. They would have that signed off. So, and ST3 onward can do the outlet deliveries as well. So if you have a labor ward going on where, there are some emergencies and stuff, but then at the same time, in some other room, there is a fetal bradycardia, and the head is occipital anterior and the station is +2 or +3 already, you can safely send your ST3 there to do the forceps delivery for that. Okay, so your ST3 can't do that level of forceps delivery, and you do your PPH. Okay. Can we refer her to other unit for C-section just because of no, that's not the Mubashira, that's not the answer here. No, we won't be referring her for C-section to other unit because it's not about the numbers only for our unit. She's booked with us, right? So what is wrong here? So the solution is not diverting them to somebody else. Solution is for us to find out, is there any clinical technical reason why we are doing a lot more serious sections? All right. A red one is not, no, it's the, yeah. Okay. So then OSATs. So in OSATs, okay, so OSATs are, you can find these forms from our CG site as well, and have a look on that. So this is a form. I mean, this is obviously electronic, but just for you guys to have this paper form as well to see. Now, OSATs are two types. One is called formative, and one is called summative. Summative, in simple words, you can take as a final exam. All right, kind of final assessment where you will say competent. You're able to do it, pass. You're not able to do it. In bad words, fail. But obviously, we don't use the word fail. So that's what the summative is. So summative is kind of your final assessment. say your exam. What we are doing now is formative, because I asked you to present the case, you present the case in all exam conditions or whatever is required. But then I give you the feedback. To some of you, I say, well done, you did very nicely. In some others, I say, you did well, but you need to make these improvements. Yeah. So these are formative. And then when you will go in the exam and you're going to present, that will be summative. So that's simple way to understand what the difference between formative and summative. So in curriculum, again, it's defined. The training ladder has been defined for every procedure. So there is a process. You can't just simply go, even if you are competent to do that, right? Say, for example, you have come from some other country to practice here, and you have worked for so many years back home already, and you do know you can do placenta previas and everything. But when you come in here in this country, again, even you will have to just go through that initially. So what you can't tell, I know these procedures, but the way is you still will have to follow that one. And what that ladder is basically there for every procedure, it is defined. The numbers are given, say, and there are 3-4 categories of that. The first one to observe, say 3 cases or 4 cases, depending upon the complexity of that particular clinical activity. You need to observe 3 cases, or you need to observe 5 cases. So say, for example, fetal blood sampling, right? So you need to observe 5 procedures of fetal blood sampling. When somebody else is doing, you're just standing and observing, and that person actually is kind of telling you as well. When we say the teaching along the management of the patient, remember your that case where you're ST2, you're teaching CTG while doing the management of CTG. Yeah. So that's what it is, observation. They have to observe and say. So they have to do those 4 or 5, say, stick to fetal blood sampling. Again, 5 cases they need to observe. Then say, for example, they need to do 10 under direct supervision. So I will be standing on your head and you do this fetal blood sampling. And if you're not doing quite properly, I will help you to say, do this way, do this way. And then there are a certain number of procedures you will do completely independent, like 5, 4, again, for every complexity number is defined. You will do that. And every time when you have done that, you will enter into the logbook, and that assessor who was with you, that person will sign as well to say, yes, you have done it, it's being done. So in the final stage, where you feel now that you have actually done these initial phases, where you are able to not do independent ones, there then you will do. So there might be a day when you come and you say to your registrar, it's not very busy, or even if it's busy, whatever you're doing, and the registrar is ST5 is there as well. Then you say to your ST5 that, I'm going to do this fetal blood sampling, but I need my formative assessment to be signed off. So will you be please happy to see me doing this procedure and then do my assessment? Yeah. So formative and summative, those forms look like similar, except I don't know why this slide is not going up. Except that on the top, in the formative, it will say formative assessment, and the summative will say summative assessment, right? So the form is like obviously trainer's name, trainee's name, grade of the trainer. It can be ST5. So any person who her or himself has been signed off and competent for that procedure, they can sign your formative. They can do your formative assessment. Okay, so for ST3s who need fetal blood sampling, ST4 and ST5, ST6, anybody can do their formative assessment. That doesn't necessarily have to be done by the consultants. The name of the procedure, clinical details and complexity. Yeah, so say for example, if it's like fetal blood sampling, like being on head is already at +1 or +2, +1 occipito posterior, she just gone into 2nd stage of labor and some pathological, and we want we want to do fetal blood sampling to see if fetal blood sampling is okay. We can actually give her about a couple of hours for her head to rotate and come down, so save her from instrumental delivery or cesarean section. Yeah, if fetal blood sampling is within the normal range. So now this fetal blood sampling comparatively will be easy. Head is quite down, is fully dilated. You just have to put the scope little tiny, little bitty on this daisy. So that's what we mean by clinical details and complexity. On the other hand, it may be just 4 centimeters dilated. Quite, woman not want to take any good analgesia other than pethidine. So she's not going to tolerate, your procedure as well as making like, jumping up and about. So this is what we mean by the complexity. Okay, so degree of difficulty, basic, intermediate, advanced. Yeah, that's about that as well. So here you would just say that, and then we need to say that was. And an encounter requested it was. It is very important, all right? So keep that in mind, because when we will be doing the scenario, it can't be, I just happened to be there. You did that and it just went absolutely, luckily it went good. And then you say, well, by the way, you've seen me. Are you happy to sign my formative assessment or summative assessment? No, you need to tell me beforehand. And there are a couple of reasons for that. Number one, for the trainee who is doing that, when we ask somebody, observe me, I'm doing this one, it's not only clinical skill which is being assessed, it's also your other skill is being assessed as well, your capability to do that particular procedure under stress, because it's natural little bit of stress when we feel somebody is observing us basically from that point of view. All right, number one. And number two, if you have not asked me to observe me, I want to do for this point of view, I may not be actually very keen observer for that procedure. Then I may not be basically paying my attention. Are you putting your knots in the right way? Are you handling the tissue in a sensitive and delicate manner and the way it should be? Yeah, there are so many details I need to then particularly look at. So if you're not, I actually may not have particularly focused and concentrated on those ones. So that's the reason. It's not just to make the life of trainees difficult. So yeah, so that should be for formative one. You can request that just at that time, just before you're doing the procedure. When you have done 4 or 5 formative ones, then you request for your, and again, it's must for every procedure. Then you are given the number of us, like you need to minimum, complete 4 or 5 or this much of formative ones before actually you then arrange for your summative assessment. And summative assessment needs to be arranged proper, as I said, like in a proper assessment, final exam point of view. So you need to, whoever the assessor will be, you need to speak to that person to give you date and time for that procedure. Okay. And then they might put you on their elective list. Say, for example, it is first date in section. So they will do that assessment that day. So that needs to be even more formal beforehand. So, okay. So then we do, so basically this portion here just explains what that is, yeah, which I have explained you already. I just explained the process of completing the procedure, sorry, this assessment form. Then the other side of the form, so basically we will be starting from here. Again, my screen is not happy to go. I don't know, in this particular presentation it always does that. Maybe it's the way I have inserted these pictures or what. Anyway, on the top here, there are a couple of more lines here. So few of these, you can say economy of the movement, like the person was not too slow and neither too fast. It caused trauma to the tissue and inadvertently just shaking because you're so trying to be fast. You're just poking things here and there and, injure some vessel or something. So economy of the movement, tissue handling, and then dealing with the problem of the difficulties when they were, what was your reaction, what you did, all those things. You suspect the injury, what you're going to do, staying calm, tell my anesthetist, told my staff, told my this and told my this. Yeah, did you do that? And on the top is obviously the difficulty of the procedure, how you handle. Did you do the pre-planning? Did you use the equipment right? Did you use your staff right? Yeah, so those were the, did you take the help which was required? So there will be all these there. And safety considerations, again, safety considerations mean when I'm doing the, say for example, I'm going to do just to quickly check if the patient gets right, our checklist, if the patient gets right, is, blah, 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 all that stuff. So they will be ticked off. Okay, so this is really objective assessment, basically. It's not, so we must actually give comment in front of each of these. It can't be just the ticks either, right? So to avoid any bias. So you need to clearly say what actually is. And then the discussion starts, okay? So the discussion goes like, first of all, you ask your trainee after their procedure, what you feel, what went well. And then obviously trainees start doing a thing, I did this, I did this, I did this, I planned this, I was prepared, she was late, second stage cesarean, it will be difficult, I did, I did ask the nurses beforehand, we're going to start 40 units into afterwards, blah, blah, all these things. Okay, whatever she faced, she did good. And then we can add up as well to acknowledge, yes, you did this, this one was very good. So we are actually going to basically superimpose the importance of those steps. Yes, it was really good, and it was important as well. You know, I like that you asked your staff, you did this, whatever, yeah. So you checked the patient was catheterized, you did this, and when, say for example, the patient started bleeding, you know, you stayed calm, you did this or whatever. Acknowledge that one as well, and then you ask, okay, so again, the next one is, so what do you think? What could have been done better? Again, avoid those phrases which can actually bring some negative feeling in that person, which can add some stress to her. So fail or, you know, what, instead of what went wrong. Just say, so what could have gone better? And then that person will say, well, yes, I feel like, you know, at that point I didn't do this, or I just did, or I was doing, say, I found it a bit difficult to deliver the baby's head. So I could ask this, or I could take help from, you know, pushing the head from below or whatever, you know. So let her think first. And if she has thought some points which we feel yes they were, we can again acknowledge and add on up this way, yes, it was very important, and then extend a little bit to say, because otherwise the risk of these tears and these are, you know, these are to avoid, that is very important. And then we can add, which we feel we have found, like, you know, they should have been, they must have been done, or she didn't do it appropriately. But again, then, and I also feel that this was like, you know, you could do this. So this is really important, you know, because this can do this and this can do this, for example. So if I now fix here the example of, there were a couple of scenarios appearing in the exam again. One is where the trainee wants to do the surgical knot tying assessment, and the other one is the trainee has done episiotomy repair with you. You know, for the assessment point of view, I think she or he wants to get it signed as a summative assessment. So the episiotomy, they done the episiotomy, but didn't score the apex very well, and the patient is still bleeding. And now this person wants you to sign off, and when you give all this exercise you have done, at the end, you feel, you come back to the front of the page, and you feel that because he couldn't, you know, secure the apex and control the bleeding or whatever, you feel this trainee perform the observed procedure. You don't feel he performed it completely, competently, obviously. We feel, obviously, I won't say that you are incompetent in this procedure, or you did not perform it competently. The word used is trainee is working towards competence in this procedure, which in other words means that you still need to work on it before we can finally sign you off to say, yes, you independently, you're fine in this, competent in this skill. And then the trainee goes off, no, I have done it. No, that was the only thing. So if we fix that all example in here. So in that one, basically, when we are doing this in the top up here, about here, so then I might have done, so this trainee did, you know, and the patient was bleeding even after as well, you know, and then the apex wasn't right, and then she, you know, whatever, that's what the notes say. So then we will say, okay, so maybe she was trying to do it quickly, and we know some of us have that, you know, they get a little bit, you know, really red type of personality, just do everything quickly and then just get over it. And in doing that, she missed the apex. Maybe she was not able to get a good exposure because maybe she didn't put the patient in a thoracotomy position. She was just trying to ask her to open the legs and do, and it's very common and usual as well. We all know, as soon as the baby is delivered, the midwives, you know, they feel we are done with the patient, particularly if the registrar is there. They just go, you know, they're doing the baby things and the mother, and they start doing this. And the patient obviously is in pain as well. She also is relieved, and now she can't take the pain of this either. She's exhausted, she's tired, she can't keep the legs, and it's hurting, whatever. And we're not having proper exposure and trying to put our head right inside and struggling with the hands to get and see. Well, this is a time if we feel we're not able to get a good exposure, we need to call our midwife and give her, you know, the speculum seems to say, can you detect this wall on one side, or with your hands at least, about the labia and all that stuff away, so I can see, is my light appropriate? Can I see properly? And if it's not, can I ask my midwife to fix my light properly? And if it's a long tear and I can't really see, should I take this woman to theater actually? Not to give anesthesia, just for a better light, better position. right? So this is the planning. This is what how you recognize and you use your stuff and everybody. So let's assume this woman, this training, just know whatever she done, and I noticed that she didn't do and bleeding and blah blah blah. No, I asked what went well, and she told me, I have done it. I did it so nicely. I did it quickly. I did it in 5 minutes, and whatever. I use the right blah blah blah, and then I was able to. And then I will say, what could have gone better? Well, I mean, there was a little bit of bleeding at the end. Maybe, I'm expecting, obviously, I don't know exactly what the theory is, but obviously this is the time. I know there was a little bit of bleeding at the end. There was a bit bleeding because the apex was a bit high and the woman was not really, she was just not keeping her legs open, whatever, blah, blah. And then so for that reason, obviously she was bleeding, and I had to then, take a couple of stitches again on the top and blah. And I spoke to her and I said, when she said what went well, I said, yes, okay, if I feel whatever was went, I'll be like, great, yes, if it was good, you did it fine. Yes, if she asked for the light or whatever, which I feel is good, I will agree what she tells me. Or if the detail is given in the scenario notes, you would get from there. And then I add up by saying, yes, yeah, I saw, there was like a bit, it was difficult, but if she has done, or even she has done that, I will say, if she hasn't particularly recognized that I could put her to the third position, and then I said, could you, do you feel if you could get help from the midwife, or even if I was observing, you could get help from me to say, just retract the walls or help me to give the exposure or change my light or maybe doing this and all that stuff. So again, we will be doing in a way, in a suggestive way, not in an opinion way, oh, you should not, or you must not in that language. Don't use those words. Just, do you feel it could help? It could make it easier, or, you could use this, or you could ask your midwife. So all that we have done over here. And then I come to this one on this front of the page, and obviously she's not competent and I want to sign here. And now she says no. So this is now called conflict. Okay. So she says no. I mean, yeah, that was a bit, there was a little bit of bleeding, which I did, and I want to do, and I need to. So the first of all, what I'm going to do is nicely, I'm just going to say that I understand, that you need to get this signed off and you want to, however, because of these, reasons, you need to get a bit more practice, and then we can just arrange another assessment, soon, maybe, in 6 weeks, 4 weeks, or in that time. And I will offer her as well to say, and if you want, I can speak to the ROTA coordinator to keep you on those ones. Just explore her first as well. If she's going really angry and upset, no, I need to get it signed off. So I can see you're quite stressed and frustrated on this. So, which I understand, obviously, you were expecting this to be signed off today, or ticked off today. However, is there anything else which you're worried and you feel pressurized that you must get it signed off today? Yeah, because there could be some general region. Maybe she's given a little bit of, she's coming to the end of her rotation, and before this year she must actually have signed off this competency, and if not, she's worrying what else. So, or some other reason, yeah, or sometimes it's nothing because that person just feels it should get signed off now. And if she has some general reason, then she says, I have, this one, then I will offer the support again, because we are not the examiners, we are facilitators, we are the trainers. It's my responsibility as well to get her trained. So then we can talk about the plan to say, okay, so right, okay, so you got only 3 months in this rotation, 2 months or whatever. And then say, okay, yeah, I see. Okay, so what we can do in that case, then how you feel about if we speak to the ROTA coordinator and try to get your most of the duties in the labor room, but I will ask her first, what about her other competencies, in outpatient or there, and if she has those ones signed off stuff and it's more in the labor ward one, then I might say, so shall we just discuss? I can't promise that I will put you in there because I don't know what else needs to be done, other trainees need to be done or whatever. So the way I will say, how you feel if we speak to the ROTA coordinator and see if we can actually get more shifts for you in the labor ward, so you have more opportunity, And then, we'll make sure that when you come on the duty, just make sure you talk to the coordinator, midwife, and the ST5 who you're working with, to also to say that, they give you the opportunity to do the episiotomy repairs. So this is first to facilitate, offer her support, give her a plan. And if she's still not agreeing, even though her logic might be reasonable, she has to rotate in 2 weeks. I can't compromise the safety. All right, we can do something different. We might extend her rotation for next 3 months, or 6 months. We can do that, but we can't. We can't compromise the safety of the patient. So what I need to do here now is to say, if she's not agreeing with that nicely and politely, then I need to say, no, I need to become a little bit assertive at this stage. Okay, so from sportive assertive now. So I will say, whatever the name is, say whatever, Jade, Jordan, Jade, whatever. I understand that you have less time left in this rotation, and I do understand that needs to be signed up during at the end of your second year. However, at the same time, it's very important. The purpose of all this training and these assessment is to make sure that you can confidently, independently do these skills, this particular procedure, to deliver your care safely to the patients. Okay. So first, let her understand that all the purpose of this exercise is this. So, and if you're not still able to, which I feel that you need to work more, a bit more on this one, then we can speak to the clinical tutor, and we can see if we can extend your rotation a little bit more. I can't, sign it as a competent today. And then if she still is not, and she's getting a bit, rude or rough as well, then my next statement will be, okay, so we have discussed this. I have given my opinion and my assessment and my remarks. If you do not agree with that, that's absolutely okay. I have, offer you the support and plan as well. But if you do not agree with that, that's absolutely okay. So this is a conflict now in this assessment. You do not agree with my comments. So what you can do now, you have a couple of options. The one is, as I offered you already, you can arrange your other assessment with myself in a few weeks or a few months time, or you can take, that for the conflict resolution, you can take it to a request to some other consultant to run your assessment. Okay, so that's the conflict resolution then. That's it about the OSARs. Any question?
Madam, as a ST5, we can do only formative, summative. We have no role, no?
Sorry, you can do what?
Summative offsets we can't sign for anybody.
Summatives are done only by the consultants, the supervisors.
Only consultants, no? Okay. And as a ST5, which are the procedures we can do formative assessment, some offsets for juniors? Like, is there any criteria or some list of procedures?
All those skills in which you yourself has been signed off as a summative assessment. So all basic knot tying and instrumental outlet, instrumental delivery, episiotomies, fetal blood sampling. These are the ones which ST5s can do as a formative.
Okay, thank you.
And then obviously at the end, if they're happy even with signing off, and there is no conflict going on, then we need to give them learning plan was left here. So still, even if we are saying they are competent, that doesn't mean they don't need any more learning. So we can give them a learning plan to say, particular some more guidelines or something, whatever. You can read from there, or watch these, or attend your surgical skills course or whatever.
Dr. Safia, sorry.
Right.
So
okay.
the ST5, Dr. Safia, sorry. So the ST5 does not sign summative. So when he gives us the summative form, why am I supposed to judge him? Yeah, I should say I'm not eligible to sign for you summative. I don't understand. If we are not supposed to do so, so why he wrote up the form?
Okay. That's That's a really good question. That's a really good question, right? So ST5, this MRCG3 exam basically is for you to learn those skills to work as a consultant, okay? And after that, you in ST6 and ST5 and ST6 years and 7 years, sorry, 6 and 7 years, you enhance your skills, right? So this is like theoretical learning of those skills. So you will be doing, at this stage, you will understand, you will know all that what it is, and then further 2 years to enhance your skills. And then when you're consultant, you will be able to do them. All right. So for that reason, this one is exactly for you to learn all the skills which a consultant needs to have. Okay. There's a difference in learning and in the application of skills. Clear?
Ma'am, in the exam, if they give the summative, we should say we cannot sign it. Huh?
Okay. Okay. In the exam, it will appear like that, that you are a consultant.
No, ma'am.
But obviously,
I
if
am
you
an ST5, they say, should I say I cannot sign this if the pay? I mean, if the trainee asks me, can you sign me the summative assessment?
Okay, so that will depend on the scenario as well then. So if that basically what happened is that that procedure was just done. So when you read that note, which will be given to you before you go in the cubicle or before you start the station, if that says that you are a consultant and this trainee has it, because you have to make sure as well from that information given and from that beforehand that assessment was requested. Okay, time and date was arranged. That is another important thing. So in this case, if it is coming as a ST5, it may be the case actually, basically one of those examples which I gave there, because it happened, you saw and she has done it, and she just then say, by the way, sign it as my summative assessment. In that case, yes, you need to say that. The other thing you need to say that, it needs to be done, and then I won't be worried about as a ST5 or consultant. I will be more focused to say that the summative assessment needs to be arranged in advance with the date and time, which you haven't done. So I'm happy to assess you for the formative assessment on this one, although that also needs to be, advanced. So you need to also pick up that from your the scenario which will be given. Whether it says that the trainee has arranged for summative assessment, or the trainee actually asks you to observe, and then maybe formative one. Even formative one, I mean, it may be formative, and informative you're not doing it, because informative as well, they need to have certain number of which says competent before they can request for the summative. So they can have a conflict even on that one as well. So these are the first two important things you need to look at. So if she hasn't actually arranged the date and time, which probably will be the case here, other than that, I won't be worried about being ST5. If it has been advanced already, was arranged in advance date and time, then that's where the discussion they want you to take place, okay? Because they want you to, as I said, like to act as a consultant, okay? Show your behavior as a consultant. But you must check this one, even if formative, does the scenario say that she asked you before doing the procedure, can you assess me? Or even for the summative. And if it's not, even for that one, you can say that I can give you the feedback, we can discuss it. But I am not able to do this for you because it's not requested, and it's one of the prerequisites of this assessment. Okay. So we have done MDT referral already in the last sessions. So I'm gonna jump. Okay, so that was maternity dashboard. That has been done as well. Okay, so quick about the consent and competency. I know you all know that already from your part 2 knowledge as well, but just a little bit revision really. So what is the consent and the capacity of the consent? So from capacity point of view, all the adult people, they are competent to give consent. We are fine to assume that unless proven otherwise, okay? What are you and why are you appearing here? Yeah. So unless proven otherwise means, you know, that if we clearly can see they're not able to bring the information we're giving them, they have some learning difficulties, they have Alzheimer's, they have something like that. Yeah, so something which proves then otherwise a normal looking and normal appearing person who's sitting to you, talking logical, you don't need to question their capacity. But even in those areas, people who are competent, they can have a temporary loss of competency, and that can be because of under the effect of drugs, maybe in accident, anything that they have gone unconscious. So there can be the temporary loss of competency. And then there can be permanent loss of competency. And the permanent loss of competency is again the people who have got some advanced, the diseases and the conditions, Alzheimer's, dementias, or any other learning difficulty, psychosis, something because of which they have actually lost their complete competency. So when we say temporary competency, yes, that's very easy. We do know if patient is there brought to A&E in road traffic accident or because of some reason and they're gone in coma, we don't need any coach to come and help us to decide this patient hasn't. And then in those patients, we know, we have to take the action. We don't even need the consent in that case. We have to do what we feel at that point of time is in the best interest of their patient. So for that reason, you guys know that most of these emergency, the CPRs and all these, we just, advance them without any worry of consent. So what happens when somebody become permanently incompetent, or they are in fluctuating state of competency and incompetency? Before, okay, so who is just the 5 points again for the competent person, how we define this person is, or how are we going to assess? We give the information and we believe this person understands the given information. And then that person can retain that information for some time. And then he's able to actually then think about it, analyze all the pros and cons, advantages, disadvantages which have given to them. And then he can actually make a decision. And the decision he can then convey back to us with some logic, where we feel, yes, the person is. So sometimes what happens is people may have very short memory type of thing. So we give them information, start the conversation, given all that to them, and for the time being, they just say and answer back us straight away to say, yes, I understand this, you said this. But then if we have any, we feel the person may not be, then maybe sometime towards the middle of the consultation or towards the end of the consultation, we then again ask them, so would you summarize what we have discussed today and what you have decided? And they will not be able to then reproduce that. Okay, so that's the one thing as well. When it goes a bit more longer, more advanced stage, fluctuating competency and incompetency. So say Alzheimer's and certain other conditions, MS, or we know Parkinson's, and there's so many of these conditions where in the beginning of the disease, people can have episodic condition in the disease where they may lose their competency as well, but then they have the relapses in between where actually they can, they're fine and they're normal. All right, in those cases, we must make sure that we try to, take that window of opportunity to discuss their treatment option and then their consent. Yeah, if obviously that treatment safely can wait till then. Most of the time here in this country, particularly when the people are diagnosed with such of conditions and stuff, they actually do make these arrangements. They are encouraged to make these arrangements of their power of attorney. Or have some, advanced directive in place where they give very clear things to say, like, if this happened to me, do this. So sometimes they can actually give their own in that advanced directive. They can write down that if that happened in this particular condition, I will not do this, or do this for me, but don't do this. They can give this, and the next stage is that they can then give the power of attorney. They will say, when I lose competency completely or whatever, then I would like this person, I give power of attorney to this person from my clinical or whatever the decision making, and maybe somebody else for financial, or the same person for financial and the clinical. Okay, so these are the two ways then the things go ahead. And how these happen then? Who is going to assess them if it just happens like, no, this person is completely incompetent? Yeah, I mean, it's very easy. If somebody is having even that fluctuating situation, the person is still in there, and other people, they want to take advantage, which may be family member or friend or anybody who want to take advantage of their situation, they might just say, no, actually, he's not competent at the moment as well, even while that person might be in that phase where actually he's competent to take his decision. But that relative or whoever, they try to override the power, the right of autonomy of that person. So in these cases, that even before any person can be actually labeled incompetent, there is a formal procedure for that one, and there are like independent competency assessment advocate, they called. They do proper that assessment. They will meet that person, and they have the ways of obviously talking to them, and that doesn't need to be clinical one. There will be simple journal discussion and things. They will just talk to that person, and then check with them, do they retain this, and what happens. They can retain whatever is discussed, they can reciprocate back and all their stuff, and then that happens, and then they will say, well, no, that person is not able to know, yes, this is incompetent, and that will be then documented. Obviously there will be a proper legal document, and then for the who will be the attorney for that person, if that person has already nominated somebody, that this person will be given my power of attorney, that's fine. That he, without any question, the power of attorney will be given to that person, unless some other family member or somebody, then at that particular point of stage, do question or object that attorney to say, because circumstances may change. Yeah, so then obviously will be another court process, but usually that will be given to them. Otherwise, usually, obviously, most of the time is the family members, and usually the family also is fine, and they agree nominate one person if that has not been nominated already. That this person who is living with that person, basically most of the time, are close by, are spending more time, they are given the power of attorney then. And that will be part of the record in GP records and in the hospital record, everywhere it will be written. So that's about the attorney. And know how the attorney works then. No, this person then, say for example, the person who has lost the power of attorney herself, no, we need to do some procedure which we feel actually, if we do, should the good chances of a recovery, they won't leave without any debilitation or anything like that, and that can actually improve her quality of life. So we do believe it, that this is in the best interest of the patient, and the attorney, the person who's given the power of attorney, that says, no, I don't want that procedure to be done for this person. The power of attorney being to somebody else does not necessarily mean they can actually decline the consent as well, which is clearly in the best interest of the person. That in those situations, then we can challenge, and then we challenge them. And the way it just like it is applied, just like the children, the way we apply it to the children. Yeah, if the parents are refusing some treatment for a child, or the child herself is refusing the treatment, and we clearly know it's in the best interest of this child, it should go ahead. Then we speak to them. We take either the court order, if that is not urgent, an emergency procedure. But if it's something emergency, somebody is bleeding, like Jehovah's, very typical one which keep coming all the time. The girl, 15 years old, I think, Jehovah's Witness, and she's quite heavily bleeding, and she needs blood transfusion, and the parents are refusing. And I think probably child is refusing as well, something like that. Anyway, even if both are, I mean, if the child goes ahead with the blood transfusion and she's getting competent, obviously we're going to give her blood transfusion. But if she's not maybe she's unconscious, or she also says, no, I don't want to take the blood transfusion because of this, and the parents refuse as well, in that case, we will actually speak to our legal team. Because the children under the age of 18, if they're clinically competent, they can give the consent to accept the treatment, but they cannot decline the treatment. And in that case, then their parents give the consent on their behalf. But then for something which we feel maybe fate or any other influenced decision, because we do believe this child under the age of 18 does not have that level of capacity to make the decision, these type of complex decisions, where they can clearly basically refuse some life-saving, the treatment. And for that reason, we believe it's the best interest they should get the treatment for the blood transfusion. So we will be speaking to our legal team, and that child will receive the blood transfusion. And then, obviously, the next step is going to go, the parents will be taking us to the court anyway. But that is defendable, because then again, in these cases, it will be like most of the clinicians in these particular circumstances, what would have they done? And then it is defined by the law anyway. In these particular scenarios, we can't do this. So that's what happens. Clear about the case of incompetency in children, as I said, like obviously under 18, child is not competent to refuse the treatment, which is life-saving for them. However, if we assess them, they are Gillick and Fraser competent, they can't give the consent themselves for any treatment. And that usually happens in basically sexual health and contraception related. Other than that, mostly the children don't have any problem to involve their parents. Okay.
Ma'am, mainly the Alzheimer's disease patients are coming. So in that case, what to be done?
Sorry, when happens what?
Alzheimer's disease patient has, and like endometrial hyperplasia there, and we are arranging hysteroscopy with biopsy. Now what to do? Their children are not coming, or their children is just for few hours. What to do for the consent? So in such cases, how to deal with? And second question, when to contact court basically for consent? I'm always confused with that part.
When to contact who? Sorry, your voice is quite resonant. When to contact who?
When to contact court or legal department for the consent. So that question is not clear.
Yeah, okay. So that's what I've just explained, basically. Yeah. So the one which you're talking about, Alzheimer's patient we want to do, and she has endometrial hyperplasia, and we are making those treatment. So we have done that scenario already. So what I think I take from your is like, if if the daughter is not there either to give the consent, if that's what you're wanting, Dipti?
Ma'am, sometimes like, daughter is only for few hours or only for one day, and she's reluctant to give the consent for her mom. So in that case, what to be done? Like clear picture, I'm not getting.
Okay, I'll explain it again. So in that particular scenario, basically, the first one we need to check with her, does she have the power of attorney or not? Okay, so if she doesn't have the power of attorney, actually that doesn't matter to us at all, whether she wants to give the consent or not. I mean, if she wants to give the consent, that does matter. If she agrees with the treatment which we are offering, which we feel is the best interest of the patient, then it's good. We can document, we can put in there. I mean, it doesn't matter whether she signed the consent form or not. Even if she signs the letter, still it's okay, but we will tell that this cannot be used legally later on, right? And we will, document. The question arises when the relatives or whoever is with the patient, they refuse the treatment which is in the best interest of the patient. Okay, so I guess that's what your question is. In that case, then I will check if the daughter has a power of attorney. Then obviously, first I will try to explain her, because she might, it's not necessarily always that they just want to be, they just want to conflict with us. So first I would, like to understand her reasons and concerns, what they are. She may not be clear about the procedure. She might actually have some misunderstandings and other stuff. And she doesn't know basically that what could be the complications about not having this, So first of all, I need to ask her concerns. I need to explain her procedure. I need to explain her the benefits of her mom having that, and not if she doesn't have what. So I explain that first. So ask her why she doesn't, and if she still says after that, and I guess she understands as well, and she still says, yeah, I do, but I know I don't want to. I don't want to give that, the consent. Now we know the MDT has recommended and said that's in the best interest of the patient that we do this EUA and do the biopsy. We will go ahead with that. So what we're going to do, we will say to her, because, it's clearly a simple procedure. it does have some, risks and complications, but the advantages outweigh the disadvantages. And in a wider clinical practice, and after our MDT meeting, it has been agreed that this is the best interest of the patient. We are going to, take a legal advice on this. All right. So then, depending on this particular woman, because it's not urgent, like she's not bleeding, she's not imminent life-threatening situation, we will actually take this to the court. And those courts are specific, separate courts, the clinical and competency. They're not those typical courts that we have to wait long for those and stuff. So our legal team, whoever the legal team obviously every trust have, we will send that all the information and case to them, and they will take to them and present over there. And then the court will give the order. And it usually is obviously wider practice if it's the best interest of the team of doctors and the practitioners feel it is in the best interest of the patient. And obviously we give that, we weigh and balance as well. We give that figure to the court as well. These are the advantages, these are the disadvantages. But the advantages overweigh this. So, this one, the court will give the right. And then we will have to do what court says. If court gives the CM in the for the girl and say yes, no, that's leave her, we will obey that. But if the woman doesn't have actually the power of attorney, we will say, well, we're sorry, but again, I'm not just going to ignore her by saying, well, you don't have the power of attorney, who bothers to care what you're saying? No, I will still ask her what your concerns are, why you wouldn't like to. Give her all that information, all that stuff, and blah, blah, blah. She might be fine after that. And if she doesn't, still we will document. The daughter, we discussed with the daughter is not, she doesn't want to have, she declines she doesn't have the power of attorney or whatever. And then we are going to say, okay, so we are going to take these orders from the court. So again, we will just apply in the court take order and go ahead with it.
And ma'am,
so we won't be doing it because it's non-emergency situation. If it was an emergency situation that the mother is bleeding heavily and stuff, then we will literally inform our legal team of the trust, and we will go ahead with the procedure. Okay.
One more question. The daughter of this woman, she was very busy. She said, okay, give me the consent. I want to go. I don't have time that you keep calling me. She didn't have any power of attorney because she said it was with my father and my father is dead and it's going to take a long time to do it. There is no advance directive for the mother. So are we going to take the court order, or it's going to be the best interest only by the doctor?
No, there is no conflict here.
No, there was no conflict. She said, just give me the papers. I don't have time to come back. I will sign anything.
Okay. Yes, listen to me. This is what exactly we have discussed in the station, and just I have repeated the information again. For this woman, that was very simple. She didn't have the power of attorney or whatever. In spite of that, what we explained to her, she was happy. She said, yes, I agree with you. Okay, yes, I'm happy as well for my mother to go ahead. Now, the only confusion I think you guys get into is, should we get the signature on that paper from her or not on the consent form? Okay. As I said already, it does not matter whether we take the signatures on there or not. We need to explain her to say, right, this consent form is a legal document. Okay. And the signatures during the sign of the person, if they have the power of attorney, then this form will have the legal capacity. In case in future, if you have any problems and you want to put some legal complaint against us or in the court, in your particular case, because you do not have the power of attorney, your signatures won't be valid. But I won't be resisting if she says, oh, I want to sign. I won't resist this. I will say, you can sign it. But legally in the court, you cannot challenge, accepting by saying that I was not informed about anything. So in that case, that's why we say to that girl that you're busy, that's fine. You can go, back wherever you need to go. We also rather need to check with her. Are you okay? Yes, we acknowledge as well. We express the empathy to say, I'm sorry that there is so much going on in are you okay? Do you have some support? And then we said, is this absolutely okay? You can go. What we can do, we can have to facilitate, because the ideal thing is we try to do things in a way that they remain simple, because we don't have the time to, even by doing the right things, to go courts and do stuff, right? So first attempt we're going to do is, we are trying to say to her, okay, So are you happy? You want to have the power of attorney? Okay, we can facilitate that process for you. So we contact your GP immediately to make those arrangements for you. And they can be done. I mean, for that one, she doesn't have to be present there. The papers and the consent, who needs to be wherever she is, that assessment or that interview can take place over there. Okay, so don't worry about this, that she's going away and how the power of attorney can be arranged within a week or 2 weeks' time. Right? And it's exceptional case. We may have a little bit more privilege of 2-week target time as well. We may go up to 3 weeks because we have reasons here, as long as we can justify them. So first attempt will be to facilitate her to say that we can do this, you know, that can be done, and what is the legal process is, we can facilitate that for you to in place. However, if there is a delay for that process to happen, your mother treatment will not be delayed much longer. Okay, so we go ahead because you're happy and you agree with us the decision which the team has made in the best interest of your mother. Simple. I will document that into notes as well. So if she signs that form, that's fine. Get her signed. The important here is that you tell her that because of no power of attorney, this will not have the legal importance. So it's important that we arrange your power of attorney and we can facilitate you for that to be done on an urgent basis. I hope that clears now. Any further question? Yes?
And Madam, reverse is possible. The power of attorney she has, the daughter has, and her concept is reverse than the doctor's recommendation, meaning she is not agreeing. So in that case, we have to overrule her, and in the best interest of patients, we can go ahead with the treatment.
So I have answered that already. No, when you will listen this recording, you will find that answer. We have discussed this couple of times already, twice. Okay, please listen this. When you will listen this, listen carefully and make your own bullet points. I have answered that. Okay, you will find that answer in this recording later on when you re-listen. Okay. Sorry, I'm not rude. I'm just, because there are quite a lot to cover today, so that's why I don't want to just keep sitting on the same thing, please. Right then, so okay, this is actually, here is the process what we do. If there are non-emergency situations, this is like when we said temporary loss, wait for the patient to regain competency if we can, and then take consent from them. And then explain option and let them to decide. If there are emergency situations, then these are really life-threatening emergencies, then the practitioners need to do in the best interest. Then even then, in that case, consultant, team, and decide, they all will discuss, and that will be documented, the name of all those people that we all felt. And even in cardiac arrest cases, you know, after the documentation we do, although we spontaneously do the cardiac CPR and everything, but CPR particularly is exempt from this. But all other ones, hemorrhage and all those cases, then it's being documented then, you know, that our team was in a field was in the best interest. And when the patient regained competency, then we inform them of the action taken and why they were chosen. Just like as we discussed in trocar injury to the bladder during the procedure, yeah, obviously no consent was taken to repair that bladder injury or trocar. We did it because that was life-threatening if we will leave it. So that's what we did. And the patient regained the you know, competency. We said when she wake up and she's conscious, we will go explain her all that, what have done and what we needed to do. So that's about it. And then now that was the consent basic stuff. Right, what next? Yes, so other important component of the consent is that this consent must be independent and voluntary. Yes, the patient may be competent, but the person is put under some pressure, or she feels some pressure to take the particular option. Yeah, So this is very important. Informed, independent, and voluntary. Informed mean, you know, and I said like person is competent but clearly refusing the treatment which we feel is in the best interest, or the person is choosing some treatment which clearly is not in the best interest. We give them some information first. Yeah, we get the information from them first by asking, you know, are you aware that these LARC methods are available? Why you want to go for sterilization? Are you having any problems? What her thoughts are? And then we told about her the LARC method, their success rate, complications of the sterilization, the consequences. It will not be funded by you. That covers your informed part of the consent. Independent, you know, we said then we will ask her, does she feel any pressure? She's in a new relationship. You know, how you feel, do you feel you're safe, you know, and that's what your is. And the voluntary again means that she should not, my husband says, or this person says today. So for that reason, be careful if the scenario starts or the conversation starts and the patient says, well, I am this, or I want sterilization because my husband or my partner wants me to have this done, or I'm taking epilepsy treatment and she's on sodium valproate. We have read about, and my partner has read about all these complications valproate can do, and you know he says that, you know, better you have the termination. No, it might be fine. I mean, they have together read in the partner, but because yes, my partner wants, my partner says to, I will just simply, again, common sense, I would just simply say, okay, so your partner feels so, how you feel about it, what you feel, and what are your concerns, right? So I would just politely put the partner away and ask her to focus on herself and tell me what you particularly want, this particular, tell me what are your particular concerns, and then I will address them, explain them, okay? And even if they say, my GP says to me that I should have a hysterectomy, so just say, okay, in that case as well, obviously GP would have done all that stuff, but even then, because we want it to be voluntary, she says, I want hysterectomy. So we'll say, okay, so what treatment already have you used? You know, what discussion has taken place between you and your GP, what your GP has done already, and then give her information and then help her to make an independent decision. Okay. Okay, so this is then now risk management. No, just is showing me her screen today and it's not coming up and down. Okay, this one is clinical governance, second pillar, clinical risk management. Okay, so what is clinical risk management? Well explanatory from the words, it identifies the circumstances or any incidences that put potentially good patients or staff or any other body at risk. And what we do about it, how we will know these circumstances. We report as the incidents, yeah, risk incidents reporting. And that's not only done when the things have clearly gone wrong. If we feel this could go wrong, actually, we just nearly missed it, that will also be reported. Then just to make our practice more safe, we have actually, even for some expected ones, they put some like cutoff line to say, after this you must report. Say, for example, blood loss in cesarean section. Up to, you know, under 500 mils or something like that is normally expected, but then there is a cut line to say if the blood loss is about, even without the blood loss, every cesarean section is reported on the, you know, as for the audit purposes point of view as well, and to go through the CTGs and stuff. Any hemorrhage that will be reported, even this has nicely been then managed, the patient has done well, it was nicely recovered, everything, still we will report that so that we can do analysis and we can learn to see if there was anything better we could have done, if there is anything which can be learned or improved. And most of the time these incidents forms, we just review them, we review the notes, and there isn't anything basically we find. They are nicely done, and we just, you know, put the over there, appropriately managed, seen, nothing, and nothing being done on that. But they are still reported, you know, for everything. So for these type of things, preeclampsia, shoulder dystocia, bridge delivery, any complication after the surgery, during the surgery, they all will be reported. Although again, it's like they have been done nicely. There has nothing gone wrong. And obviously the things that have gone wrong, they obviously absolutely needs to be mandatorily reported. And what is the purpose of doing that? The clinical incidence reporting and clinical risk management is absolutely and purely for the learning and the safety purposes. This is just to ensure the safety of the practice. And it's absolutely non-blaming. Non-blaming means, so every department do have a clinical governance team. Usually for obstetrics, it's a labor ward consultant, and then there will be some midwife and then some trainee or whatever. When the incidence form is completed, the name of there is a private part on this form. Obviously, the person who is reporting, the person needs to put the name as well, and the patient name, so that we can identify which patient records we need to look into. But that is the confidential and private. That is that only say if I am the lead, only I will be able to see that. Okay, nobody else can access it. So nobody else has the access to that, and we can't use that to then I review that and then I call my that ST 3, 4, 5, whoever that person involved was, to tell that person off what you did and why you did. Yeah, I wouldn't even call for feedback purposes as well. And the reason for that, why we don't do that, why we why we need to do this, because and usually these are incidence forms are basically filled. It's a responsibility to fill that person who was doing that procedure. So if I have done something wrong, if I know that the consultant is going to call me, make me to tell why this happened, or it's going to get discussed and I'm going to get, why will I report it? I will try to hide it. Yes, for the time being, all the people know who are there along with the team, but they might just gossip a little bit by saying, well, Dr. Chapin, she's not really competent and blah, blah, blah. And then they forget, everybody forgets. That's a different thing, to feel a bit nervous at that stage, but then getting, answer it and explain it and that. So for that reason, it became really necessary that it will be non-blaming. So people feel free, that this happened, they put into, and it has actually become very encouraging environment. Most of the time, at senior levels, consultant, all of us, I mean, sometimes we feel, yes, it was a difficult patient or something, a little bit went, and they may not be, but we still put this as so that it can be reviewed. Some other people can review it as well. There can be some discussion which can take place, and we can learn, was there anything different we could do from this? Yeah. So that's why it's been reported. Learning when the things have gone wrong, to look then what could have been done better. This evidence cannot be used as an inquiry either. So be very careful when in any patient counseling, when you guys say, particularly when they are angry or unhappy and they're complaining, then sometimes you guys use the word to say, we are going to do an inquiry on this, and then we will find out and we can share those details with yourself. No. The word inquiry is the wrong word here. It's not inquiry. Inquiry means we will look into the matter, see what went wrong and who did it wrong, and then make that person answerable. And telling to you means, again, that's the outcome of the inquiry. No, the risk incidence analysis and the reporting, that is not shared with the patient. That is not shared with anybody else at all. That is just for the team learning. And when the meeting happens and we discuss those cases, their names are not even said. Date will not be said, so they shouldn't be identified who did it. It's absolutely for teaching and educational purposes and learning purposes, and then to identify, and if any interventions needs to be made, to put those interventions in place. If the gas analyzer is not working, that also is reported as incidence form. Okay, so we do that and we see, okay, that is not working. What if there was just a temporary one-off today that it was not working, and how we get it sorted, or it's happening repeatedly? If it's happening repeatedly, change it. All right, so that's what it is. The most common examples are like, all the cases of these, like APH, PPH, blood loss of certain limit. Every unit will have the limit. Don't take these limits as they are just like, I have just randomly put these figures, okay? So they can be different. emergency serious sections are reported, a baby born with poor Apgars, our pathological CTGs when we do, then those ones as well. Intraoperative complications, obviously, they all need to be reported. So these are the three main steps of this form. The first one is obviously incidence reporting, like completion of the incidence form and then submission of that form. So the forms are now obviously electronic, but and when you're doing it, probably they will show you the electronic form or whatever, and otherwise there will be paper copy. So the forms, as I said, like very simple columns in the form. They, you know, on the top it will say the name of the person who's reporting. They are obviously template fixed forms. Name of the person who's reporting, date and time of the incidents, the persons involved. Yeah, so involved person means obviously the clinician or the midwife, whoever they were doing, and the patient, they are the name of those people, and then and that one is just, as I said, like the confidential one that will be accessible only to the team who does this analysis of the incidents. That won't be accessible to anybody else at all. And then it says, usually the first column is, it says like choose the category, and the categories are again by saying whether it is clinical relevant, clinical activities, workforce related, or some falls or something. Yeah, so workforce, you need to then identify your that category. Let's see if I have to put the incidence. Give me 1 second. I actually find where that form is so I can show you. Okay, so this is how they look like. So this one, sometimes they will say, put your practice code. Obviously, that's the department thing. Please describe what happened, date and time when the event took place, where. Usually they have given the places as well for the department, this department, this department. You choose that one. Then categorize from patient safety point of view. And the safety is again like severe, mild, harm, whatever. So you just choose from the drop line. Was the incidence a never event? Never event are few those incidences which should not happen. You know, they are so obvious and big, like operating on the wrong side, like instead of right, you operate with the left, instead of right kidney, you remove the left kidney. The patient was for copper coil insertion, you did marina coil insertion, or marina coil insertion, you did the copper coil insertion, something like these type of major things. Was the incident shared or discussed with the patient, carer, or family? You know, obviously we do discuss with them when we explain that this happened, because we need to tell them if something is wrong or whatever has happened. And then the grading of the harm, what happened. No harm happened, low harm, moderate, severe harm, or death. You know, obviously you need to tell the outcome there, what happens. Age of the patient and incident occurred. So these ones here, date of birth of the patient, are they are usually confidential. They will not go to anybody else. Yeah. So the patient or the people involved, they will not be identified from these. But this is usually a standard form. How do they look like? Okay. So I want to get rid of you now. Okay, so simple. Okay, so what we basically do, so we take that submission comes to, and then we look into, again, we review what is written over there, then we get the notes and see, you know, what exactly, is there anything which could have been done differently, or what went wrong or what not, are there any suggestions? And when they are, then we feedback and recommend by risk management team for the future. So we do have some departments have weekly risk management meetings, some have fortnightly. So that depends, or monthly. That depends on the size of the department. And there, those cases are again just randomly and anonymously discussed. So maybe if it was about some pathological CTG and the baby was born with a very poor upper scar, and that has been, you know, discussed. So the way the discussion take place is as they not that they describe the incidents and tell you the end what happened. That particular, no, the team is sitting over there, so they, you know, just whoever the team is who have reviewed this, you know, they will just say that, you know, this woman, tell the whatever the woman came with, blah blah blah, and that CTG whatever, and then they will ask the whole, because it's a learning activity. That will be asked to the whole team, you know, from what will you do with this CTG? Is the CTG satisfactory? What else we need to do? Any questions? Then you go next part of the CTG where it goes pathological or whatever. What should be done here? What you feel here should be done. Discussion takes place. This is how it should be done. And then you know, about the decision and everything. And sometimes if something is done quite wrong, you know, clearly, then it can be discussed openly in that way, that, you know, this incident happened and this was the outcome. And that will be again started from there, you know, to say this happened, what should have been done here, what could be, and then the team give the person who have done the analysis and recommendation, they will give as well, like we should do this, and this should have been done this. And then sometimes we put the recommendations in place as well by saying that, you know, that this should be done this way, do not do this, call this, you know, consultant if you have. So that's what it is. Slightly different from clinical audit, which is a detailed, you know, practice of a lot of cases. This one is just particularly for that one case, what could have been done, what we can discuss, and how we can put the system in place. Yeah, okay, so that's, here is the form. Yeah. So yeah, usually this is how it looks like. So if you look at the beginning, do not include patient identifiable information. So when you are describing the case, then you will not put that information. At the end, there will be asked from you. So you can tell what was the type of the incidence. Usually the drop-down list is given. But then again, as I said, whether it was a clinical relevant, it was workforce or whatever, then give further description of the incidence, what happened. Reporting organization will be the department name, date of incidence, time, what happened, where it happened, reporter's name, your job title, reporter's telephone number, and then you tell the patient details again, because the person who's going to analyze, they need to retrieve the patient notes, but then again, that will not be accessible to anybody else. Then what happened? Just simply describe. And when you're describing what happened in that one as well, you're not supposed to basically give your opinions. You just simply state the facts. Okay, just literally state the fact that this happened, this happened, this happened. That's it. You won't say I feel this happened, or this shouldn't have happened, or this is how it should happen. No, just simply state the and then your own. Okay, we have done these details already. And then, so the person reported all that incidents, described what was happened. Then the person who was doing the analysis, they have done, that's what lesson might be learned and shared with others. So the person will write all those comments over here by thinking, whatever we felt. And how you identified any factors you're not in a position to change. Sometimes there may be things which we can't change. And then we might need to write down, say, for example, the factors can be, the incidents can be, there was a very low number of staff that particular day, okay? Where actually it breached the safety proportion. When we said like there should be midwife to patient ratio should be 1:3, maternity dashboard, the one midwife should not see more than like 1.3 patient at one time, right? Now for that day, now we were supposed to have 8 midwives and we had only 4 midwives. Okay, we will do something long term afterwards, but what to do now immediately at this point of time? So then we reported the incidents as well, and then we did the incidents, and then we found actually there was heavy snow that day, and other people just were struggling, was slipping, having injuries, cars gone other way, whatever, and they couldn't. So that is something we cannot change. We're not in a position to change. So this can be that as well. So action plan, who will then look after if there is something significant which we need to change, and by one, again, the same thing as we did in the audit, but that only for that one particular. Then you categorize the harm as well, which you feel, was it no harm being done, low harm, moderate, and then you just simply tell what that harm was, severe harm or death, what happened in that particular case. Who is the clinical risk assessment team? Usually clinical governance lead consultant, who mainly is looking after all of these things, basically. Maternity dashboard, audit, is a clinical audit lead as well, and these risk managements, looking into complaints. This clinical governance usually is one consultant is the lead of that team. And then what happens, these are incidents when we have done them, then obviously that is, say, gynae department, gynae ops, then that needs to go to be reported and go into the trust. So there is an overall trust team as well, where these things need to go, because there may be few things which we need to have an assistance from, we are having maybe quite a lot of slip accidents on our entrance of the maternity unit, just because of some obstruction over there or something like that. And we have analyzed and we feel that entrance needs to be changed. Then we need resources, we need more than just within our team. So that for that reason, obviously the trust risk management team needs to be in place as well, who will just then make. So as I said, like these meetings within the department usually take place weekly. In obstetrics, particularly obs and gynae, other specialties may be different, but if some unit is very small, district hospital, they might do fortnightly. That really depends on the number of their patients and cases. And then in the form at the end as well, there is a given, in the side, there's all information is also given for you to, if you don't know which one you should put as a serious incidents, which you will say as a never event. There is a list given again for those ones. So completing risk incidence form is not no science. It's just simple process. It's given over there. Everything is, if you don't know what it is, there is a detail given. What is, everything. You just need to literally read and tick it off. And then usually there is an email address given, whoever that person is. I mean, this one is just like just random, but usually there will be the email address of that your consultant or the midwives or whoever. Those 3-4 people will be given, and that usually is then again reporting to, and then there is a drop down list. You just click on those your own department person. Any question? Any questions?
No, Dr. Bean, thank you. You have explained everything very well.
Good. Right then, so we go now to undermining. Right, who wants to do this now? Then obviously we can do this as a role player. What is your list order today, Pramila? Actually, we may not be able to go. Actually, everybody get the opportunity here because there are just a couple of. So the one who feels they have listened the recording really well and they think they presented good, please come that volunteer ahead.
Lubna was the first in the list.
So I'm not going to stick to your list order today, Pramila. So among yourselves who feel that, obviously I don't expect an ideal.
Or else, ma'am, who have got place for the exam, let them do today.
Okay. Come on, girls, then. Who wants to do it? Okay, Sadia?
Yes, I can do it.
Yeah. I just put you, please, I'm not like kind of, again, just because I thought because you do that anyway, here as a part of you, so you can just add on to it, yeah.
Yeah. Okay, I'm happy to start instead of 2 minutes.
Okay, yeah, that's fine.
Hi, Emily. How are you?
I'm okay.
What happened, Emily? You seemed quite upset and you seemed quite tearful. Should we go to a side room? Let's go together on a side room. I will tell the coordinator to catch us if she needs any of us in an emergency, and we can go to the doctor's office just on the floor.
Yeah.
Okay. Now here we are alone, and as we are working together, you are a part of our team. So just please be open and tell me what happened. How can I help it?
I don't know, to be honest. I should really be discussing with a lot, but yeah, I'm quite upset. These two midwives, XYZ, they've been really mean with me, and I have noticed they always like try to undermine me, and I'm quite convinced they don't like me, and they are just always after me. They really do upset me at times.
Oh, I'm sorry, Emily, that you have to feel like that way. Oh, just have a seat. I'll make a cup of tea for you and we can talk over the cup of tea about it more in detail. And in the meantime, you can quickly recollect about what happened and you can discuss it with me. Don't worry. I'll try to help you out the best I can. Okay? So, can you now tell me, how do you feel about it? What happened and what made you feel that those midwives are undermining you and they are not being nice towards you?
So, I mean, you know, this is my, like, obviously the first year of training, and I'm here only for 2 months in this unit. And I mean, I'm trying my best. I do, you know, whenever they bleep me, I come down, and, you know, whatever they ask me to do, I just do that. But the way they behave to me, and particularly in front of the patients, they do behave as if I don't know anything. And I'm not going to do things right. You know, it's just not, it's not right. And they do upset me to the extent that I do really fear now when I get my duty on the labor ward.
Oh dear, it's going to affect you very negatively. Um, so what happened today? Today, did they talk back to you in front of the patient?
Yeah, I mean, they called me, you know, she bleeped me, and then I was in a gynae ward. I was saying I was doing the catheter of one lady, and they told you know, they told me to come down to do this cannula, and I said, well, you know, I just do this and I will be coming down, and I did. But when I came in, one of them was doing the cannula already. So as soon as I entered the room, she just literally said, we don't need you anymore. You know, and you can just leave. But the way she said was very rude. And the other midwife, you know, the XY one, she came in and out, and she said, well, you wouldn't have been able to do it anyway, doctor. Go do something better. And, you know, and that was like in front of other midwife.
Do you remember who was there? Do you remember the names?
Yeah, XY and YZ.
Okay. And on the previous occasions, these particular two midwives, you have told that they have been mean with you. Have you noticed that the other midwives or nurses in general have been complaining about you or not happy with you or anything that they have expressed or showed you?
No, everybody else is fine. The midwives are fine. They don't. Nobody else have complained anything. No.
And have you talked to anyone about it? Any colleague or your supervisor?
No, I haven't. I haven't spoken to anybody because, I mean, both of them are really senior midwives, and I don't want to be in trouble. No, I haven't.
Okay, first thing I want to tell you, Emily, that if there is a serious concern about them undermining you or bullying you or insulting you in front of the patient, which should not have happened, because if there is anything, any constructive feedback that they want to give you, they can take you on a side and can give it to you when you can then try to learn something from the incident. However, it should not be happening in front of the patient. I will definitely have a chat with both of them individually and see what has made them do similar things. I will definitely escalate it with the coordinator, and then we can talk about it. And I would encourage you to talk to your educational supervisor about it. Have a meeting arranged, because in NHS, don't feel frightened. We do have a very strong system to stop the bullying and undermining, and we definitely have a very, very strong system in place for dealing with such situations in a very sensitive manner. Okay?
Yeah.
And,
okay.
And if you do not want me to talk to those midwives because you are frightened that they are very senior and they can bully you or they can harm you in any way, then it's okay. I wouldn't go and talk to them, but I would still want you to escalate it to the consultant. I will also send an email and tell them. And I would
thank you. So thank you, Sadia, for your concerns, but I'm not prepared to do anything at this stage, and So I will really appreciate if you don't send email to anybody at this stage, please. I will see, you know, I will see. And when I feel ready, then, you know, I will come and speak to you.
Okay, that's totally fine, Emily. If you don't want at this particular time, that's perfectly fine. However, I would still encourage you to write down what happened along with the date and the persons present witnessing this incident, what happened today and what happened on the previous occasions when you felt upset with the behavior of these two midwives while the memory is fresh in your mind. So write it all down
Yeah, I will do.
along
Yeah.
with dates and times. Yeah.
Okay.
And in future, if you want to change your mind, you can always escalate it. And we do have another very sensitive team, which is Guardian to speak up. They can deal with bullying and undermining if you want to talk to them at a later stage.
Yeah, we'll see, Doctor. Yes, Adya, we'll see what to do with it.
Okay. Are you feeling
No,
okay
I
to
can't
carry on your
think
duty
straight
now?
at the moment.
Sorry?
I mean, I'm feeling really, really shaken up at the minute, but I think I'll be all right. I'll have a drink, and you know, if you don't mind, if you can have about 10-15 minutes on my own, and then you know I will be all right to come on the floor.
That's totally fine. You can sit here. I will carry your bleep in the meantime. I will go and see if there is no emergency going on. You can definitely take a 15-minute break, sit here, let your mind get calm. However, if we see that there is an emergency going on or we cannot manage the break at this point, I'm happy to talk to the coordinator or the consultant to come and help me with that emergency while you try to cope it up. However, if you are really not feeling well, you can always go home and I can talk to the rota coordinator and the consultant that if there is someone else who can come and do your duties here on the labor board, that is also an option.
Yeah, thank you. I really appreciate it. Yeah, thank you very much. Yeah, I'll see. I think I will be all right. Just need a little bit time to just you know have something to eat and drink, and then I will be all right.
Okay. And Emily, in future, if these midwives, even today, if these midwives, they speak back to you and they behave strangely to you, I would in front of me, I would definitely intervene and have a word with them. Is that all right?
Yeah, that's all right, Doctor. Yeah, that's all right.
Okay. I think it's done.
All right, thank you. Thank you. Thank you very much, Sandhya. Have a nice day. Nicely. Yes, okay. So, yes, so Sandhya has covered a lot of it. Bit more to add to this. We need to look after her and give her some other alternative ways as well, and about her. So you did discuss, you have addressed beautifully her immediate needs. About her both emotional and her physical need, offering her to take some time, sit here, yes, you know, I carry your bleed meanwhile, and then reassuring her we can, you know, arrange somebody else to come and cover, or we can do so, removing the pressure from her, because if she's not feeling safe herself to continue to work, she must go home. So the immediate things we have done nicely, but we need to give a little bit more thought beyond that as well to her. Yeah. So although she says, I'm not happy to do anything at this stage because, and she's clearly said she's frightened. She might, you know, she might have the consequences because both of them are serious. So we need to tell her the ways as well. So to start with, yes, absolutely. When you see this, it's very important that you do call that just in a natural way to your colleague. Don't ask, I am this and are you this, confirm your name. No, they hear this person who is working with you and particularly is on duty with you today, so you definitely know each other. So just, you know, in a friendly way, just ask, Emily, are you all right? I see you're not, and obviously that person will appear a bit upset or disturbed. So I see you're not quite, you don't seem to be quite right. Are you okay? and then see what the answer comes. And then, yes, you can offer her to say, so shall we go to the doctor's room to have a bit of privacy over there? And then we can talk about it. And then, yes, so then you assume you're in the doctor's room, and then you say, so, but offer her. I mean, it's absolutely fine the way Sadia has done, give very direct question to say, tell me what has happened. Sometimes that person may not be quite ready because of the reflexes or the thoughts and the fears she has to clearly tell us exactly what has happened. So it's better to give a little bit of flexible way to ask them by saying, so again, you said, I can see you're clearly quite upset. So if you feel you can actually discuss with me, I mean, it will be confidential, it will be private. I won't discuss with anybody else unless you would like me to do so. So because maybe Sadia actually is very good, you know, those midwives actually get on very well with Sadia. Yeah, and it's not unusual. They are pretty, you know, whoever it is, they might be very good with other staff member. You are going to talk, yeah? And registrar, they might be very fine anyway. So they're fine with Sadia. So when you're asking me, I might just feel, I'm not sure I even want to tell you about these two women. So yes, I will give flexible question to send this. So like, so, you know, I can see you're so upset, and, you know, and I will be really happy if I can do something about it. So if you feel so, you can, you know, trust and discuss anything you want to, and I can assure you it will be quite confidential and private, and I will not discuss with anybody unless you would like me to. And then, you know, ask her to encourage. So, you know, would you like to share with me what is upsetting you so strongly? And then let her, she will tell you then what has happened. So stay calm, let her talk more. And so when she said like this happens, then it was good that you did ask about. So wish you know, tell me some particular event, what happened. Yeah. So that also helps us to also feel and understand that, you know, is there really bullying going on? Because sometimes some people are just a bit more sensitive about everything. Yeah. So it could be equally that as well. So just ask, would you, if you don't mind, will you just describe me exactly what event happened, what has happened? So when she described that event and that all happened, and then yes, first acknowledge it, but say no, that's absolutely wrong and absolutely unacceptable. This is not how they should have behaved. And then you can ask her, so how this has been happening before as well, and how long is that going on? And then you can say, so has anybody, you know, any other staff around when this happens, like any other colleagues, registrars, or any other midwives have watched this happening to you as well, and have everybody ever tried to intervene or said anything about it? Suppose to establish that one as one going on. Then you just check by saying, so what is your observation? Are they like mean or nasty only towards you, or you feel they are doing this to your other colleagues as well, like other junior doctors as well? So establish that as well. And then you can say, and then the next one will be obviously very that question, that have you discussed this with anybody? Have you tried to speak to them? You know, that their behavior upset you or anything, or to anybody, you know, your supervisor, or to your other, you know, your colleagues or friends here. So that will be the next question to ask. And then after that, I will be worried about how she's coping, because she said, like in the morning, I do feel so fear when I, you know, when my duty is here on the delivery ward. And I will say, that's, you know, I'm so sorry that you have been feeling this way, and it's awful. You know, this is not how it should feel. But then I will ask them, so right, okay, so tell me then how you've been dealing with all that stress and all that, you know, have you been able to sleep properly then at home? And, you know, are you able to eat and drink? Is that affecting your family, you know, when you go home? Have you spoken to somebody, you know, your partner or your any other family member? And then try to assess your physical aspect as well. Like, do you suffer, do you feel then, you know, when you're at work, that you're able to actually focus and concentrate well at work? And if this is how you feel when you're on the delivery, do you think this might be actually affecting your quality of the care you're providing to the patients and quality of work? Because obviously that's not good feeling, that's quite nasty feeling, and it can affect obviously our you know, the level of care we want to provide to our patients. So by doing that, just explore, because this is by doing this indirectly, we are assessing her whether we should, because sometime when we are going through and then being, you know, not only junior doctor, we are even being consultant and senior as well. Sometimes we are unwell, we are struggling, yes, we are stressful, but it's not easy basically to go on sickness leave or take time off either. We do feel pressure in spite of all that support in place. The system says yes, you can't take, but still there is pressure. We do feel the pressure to stay at work, you know, because we feel we don't know how long this is going to. I mean, what I say, why can't I come to the work? So that's why it's very important, and also to help them. Yeah. So from that physical, I will go to that first before the other clinical things what we're going to do, and then I will encourage, if she give us clear signs that she's at home as well, she's struggling, not sleeping, eating very well, and all that stuff, then I'm going to encourage to say, well, I will really strongly encourage you to get some help, you know, about that. And I will discuss you in a minute about that, what actually you can't do. And then coming back to the incidence things, you will say, okay, so how you feel about that, to do something about it. Yeah, so first see what she feels, so that if she has any concerns or fears, I don't want to, but then you will say, okay, so are you aware that, you know, obviously, you know, we do have a trust policy as well. It's absolutely, you know, zero tolerance to any undermining, bullying, or any type of harassment, and we do have a trust policy and that as well. So, you know, that does provide you that protection. So do not feel worried about or fear about that, you know, they're senior people or whoever they are, and if you complain about them or you try to do something about, you would rather be penalized, or they can victimize you even more. No, it won't be. Nothing like that will happen. So how you feel about then to do something about it, like maybe to start to, so I will be saying maybe, yeah, maybe to start, I mean, if you want, I can speak to those midwives, and, you know, I mean, the best thing is, if you feel so, if you can't do, to talk yourself to them and tell them their behavior is causing that upset, which usually is always no, because that person who is frightened so much is not going to confront them. And then I will say, okay, so how you feel about that, to discuss with your supervisor. Okay, and do not worry, as again, as I said, like, I reassure you, you will not be further victimized. It won't be put in a way. I mean, there is a proper process in place, you know, to heal with that in a sensitive manner. So maybe they themselves are not actually aware that their behavior is causing so much upset to you. So they may not be actually aware and doing this intentionally, you know. So I will strongly encourage you to you know, think and speak to your supervisor, because you know, if they are doing this might be actually causing upsetting the other doctors, the junior doctors as well. And then if you feel so fearful to commit to the work, obviously you're not going to, number one, to perform your duties in a well way you should be, and second, you won't be able to learn and have the training which you are supposed to have. So for these reasons, it's really important. So how you feel about it then? Yeah. So consultant, if she says it usually is the case, I'm not quite sure, and I'm not sure I want to do anything about this. I will have a think. And that's absolutely okay. So right. So let me just tell you some other resources as well. So are the other one thing else you could do? You can speak to BMA, yeah, British Medical Association, and then check with her. Are you a member with them? And even if she's not, if she says no, then still you can say, so, you know, this is the number. I'll give you the contact detail for them. And that is association. They particularly work for the protection of the doctors, you know, their rights, to ensure they are safe at the workplace, no bullying and harassment happens with them, and they're very supportive. So give them a ring. They will then, you know, listen your case. They will give you the way how to deal with them. And if you feel you yourself actually don't feel like you can approach anybody and you want to speak to, they can actually write a statement on your behalf, discuss with you what you will say, and they can actually communicate, you know, whoever you would like. They can you know, send that to your supervisor. They can present you basically, okay, or whoever is. Or if you feel yourself, you can speak to the supervisor. You can, if you don't feel comfortable, you think you can't speak to your own clinical supervisor, you can speak to clinical tutor, or you can directly, you know, speak to the HR. We can look at the detail, who is they actually safeguarding on this, like bullying and harassment, anti-bullying and harassment relevant HR you can speak to. So you do have so many people around and so many other resources you can use. I will, encourage you to must do something about it. Right at this stage, if you assess the way you assess her safety, do you feel you feel enough to come down? And even if she doesn't say, I will say, don't worry, take about 15-20 minutes here, have something to eat and drink. I carry on your break meanwhile. And then after that, we will see. If you still feel like you're feeling a bit shaky, please don't worry, don't feel the stress, you must stay at the work. We will check if somebody else can come and cover your duty, or we will do, you don't worry about it. We will see what we can't do to cover the obviously the delivery suite. So, and then for a bit more long term as well, I would encourage you to see your GP. You can take some time off, to take some time to just get this stress relieved, look after yourself, and then you can have some counseling as well. So the counseling can be arranged through your GP, but if you don't want it to the GP, there are some confidential services available as well, like you can assess that through the occupational health. And that's totally independent, confidential service. It will not come into your recorder anywhere. Or again, if the best I will suggest is through BMA. BMA also have that counseling service for the doctors, and that's done by the doctors. That's a good thing because they do understand exactly what we are talking about and what type of culture and environment it is, and they can really help you in that way. So give her that one as well, to offer her this, and then say, so what I will do instead of just first time volunteering that I send email to this and this, at this stage I'm just going to encourage her to start doing things, offer my support to say, if you would like to do, you can, if you would like me to speak to your supervisor, or you would like me to come with you when you go and speak to them, I will be very happy to do so. So how about if we, just put some meeting for us just to catch up again maybe in a week time or in a few days again, to catch on things, other things are going on, and at that stage we can then again pick up what you want to do and how you can proceed with it. All right, just like as we give the women that opportunity, if they're not prepared to do anything that particular day, we say them, okay, these are the options, and then arrange another meeting with them to say, so we can just help them, because she might listen to everything go and then again. And I mean, it's really amazing how basically, again, I mean, when we read this or hear this, it's either, well, yeah, I mean, it's so easy. If somebody's causing us upset, go and complain about them. But no, actually, the people who are the victims, it's really amazing. I mean, when we talk to them, they're very good, whether they're doctors or the patients. I mean, they're very good, they're confident, they're so good in everything else. But once they start getting, bullied by somebody, they really shake up their self-confidence and things and everything. And they do need a lot of support, even, to encourage them to take the fear away that even if they did something, they will be further victimized. Because it's not normal and natural feeling, isn't it, that we have to still work with this team for the next 1 year, or even if you're working as a consultant now, one other person, you feel that I'm going to work with this team whole life, rest of my age of my retirement, and if I do things today, I mean, how I'm gonna, but it's not actually. When the things happen, they're done then, yes, for the time being. I mean, don't say that as a part of exam. It does happen for the time being, but then overall it's fine. The people do, and the people who, and most of the time it appears when we speak to those so-called perpetrators, most of them, particularly the staff to staff one, they get really shocked by thinking, no, I have not been doing that intentionally at all. This is not what we meant. Oh, I'm so sorry, that's not what I was doing. And that's all it takes. And then they speak to the person as well, apologize and say, give comfort to the person. Absolutely, no, that was not our intention, and that was not. And then they change their behavior, because it's just maybe some people are, you might have seen, some people have stronger tone, some people have a bit stronger, loud volume the way they speak, and that does appear in the beginning, unless we have spent some time with them and we know them. It does feel a bit, rude about certain people. So that's why these processes are in place, and they're very important. Any quick questions? Thank you very much, Sadia. That was very nicely done. Just add up a little bit of this, a bit more long-term thing.
Thank you, Dr. B.
Okay, no concerns and questions. Shall we take a little bit break? I don't know, when I do this session, I get overexcited and I forget to take break and eat and drink, but I'm pretty sure you all must like a bit break. So let's have a little break. And then we come back and touch a few more important things. So 20-minute break. 20 to 3. 3:15. Okay. Is that okay, girls? Girls and boys?
Yes, that's fine. Thank you.
Okay, hello. Okay, so next we will do reflection. So you do get some illustration on this. This is one of the recalls. So who would like to do this?
I can try, Dr. Safia.
Okay, good. Okay, yes, first 2 minutes. Did you want to start?
Yes, Dr. Safia. Hello, this is Asma. Is this Millie Campbell? Hello, Millie.
Yes, hello. Yes, hello, Dr. Malik.
Yes, Millie, I know that you're here because you want to have a reflective session with me today. Uh, um, I can see that there was a patient which came 2 weeks ago. So can you tell me more about what has actually happened? And
Yes, so yes, Dr. Malik, thank you for giving me this time. I just wanted to, reflect this case, this lady I saw. She was 29 years old, and I saw her about 6 weeks back. She came with very, with pain in lower part of the tummy and with spotting like bleeding. And I saw her. I mean, she was quite well. Her pulse, blood pressure, temperature, everything was fine. And I just, palpated her tummy. There wasn't any particular tenderness or anything. So, I just thought she's kind of, she probably is maybe threatened miscarriage. So, just give her some paracetamol and then send home. But then, I learned that she came in the night with rupture ectopic. She was actually brought to the hospital by ambulance. I touch wood, she's fine. She did fine. I mean, obviously she was taken to theater state, and she had right self-injectomy. And I have been able to see her after that as well. So, I mean, she was fine, okay, but it just, I just was wanting to reflect a bit to see what could I have done different, really.
That's very good, Millie, that you have come up to this point that you wanted to know something which would have avoided this incidents to happen. But Millie, when the patient arrived, you told me that she didn't had any particular history that was suggesting of thinking towards the ectopic pregnancy. So, did you arrange for the pregnancy test?
Yeah. I mean, pregnancy test was done already in A&E, and that was positive.
Okay, so why you didn't arrange for the scan, right?
I mean, she was like, she wasn't very heavy bleeding, and I told her, like, if she bleed heavy, then good. And no, I did book her scan.
Okay.
Which was next week. Yeah.
So most of the time, so what was her last menstrual period?
That was about, I mean, she was like 6 weeks, about 6 weeks she was.
Okay, so that's sometimes when the woman present with 6 weeks of pregnancy and the pregnancy test is positive, and in the history you need to ask few certain points, which I think you would have asked, as you told that you took a history properly. So after evaluating the history points and doing the examinations, sometimes you might not have a clue that this might be the ectopic pregnancy, even after this history and examination, because sometimes these ectopic pregnancy are sometimes they are no, the patients are stable, and we might not get an idea even after arranging the scan. But still, you need to, in these patients, you need to know that what the pregnancy test quantification of that beta HCG levels are, because this might give us a clue regarding particular values that, for example, if the beta HCG is 1000, so you should have seen this pregnancy on the ultrasound scan, and if it's not, then you have to arrange for the further follow-up of these patients. Are you following me, Millie?
Yes, definitely, yeah.
So now for these things, that was a very good thing that we took a history and you arranged for the pregnancy test. But in this case, you should have arranged for the scan and also the quantification of beta HCG level. Okay, Millie?
Yeah. I mean, I don't know. I to be honest, I really don't know why I missed it. Obviously, I do know.
Okay.
I should have, sent her beta HCG and, to do her speculum and manual examination as well. It's not something, I mean, we do that all the time to the women coming with pain in early pregnancy, but
Yeah.
actually it was so busy that day. We were really, it was really hectic and busy call, and it was like the bleed was constantly going on and on and on. Like I was just literally rushing from one to other, and so that I was spending more time answering my bleed rather than seeing the patients. And the ST5, she was like kind of also just jumping in and out of the theater, which is one of those typical nights when everything is just so busy. And I mean, I was really tired as well, I must say. I didn't get any chance to eat and drink.
Yeah, that's yes, Millie. I know that sometimes with the hectic routine, these things can miss out. But when you feel like that you your senior ST5 is also busy in managing some such kind of emergencies, then you can always contact a consultant, and that's a very good thing. Even consulting a consultant, even in such points, can make a bigger thing, or we can avoid such things happening in the future. So I would really encourage you to always discuss such kinds of things to your consultant. Okay, Millie. So and whenever you feel like that you're over hectic or doing a lot of work, and because of this you're missing such kind of patients, you're always welcome to contact to the midwife coordinator to talk about further, to arrange for the further help. Even you can escalate this to ST5 at the same time, and sometimes you need to discuss all these things with your consultant. Okay, Millie? So what
Sounds good.
actually
That's fine. So,
Millie, so what actually you've learned from whole of this scenario afterwards?
I mean, yeah, same thing. I mean, I did know it already anyway. I don't know. I just missed to focus that I really. Obviously, yeah. You know, with these pains, with the lower tummy pain, we need to do biomanual examination and send them beta HCG. I don't think. I mean, when I see that she was so well and stable at that stage anyway. I mean, I don't think I could have done anything different. I mean, I would have sent her home anyway.
Yeah, so
But
most of the
yeah.
yeah. So Millie, most of the time when you feel like that there's nothing on the scan and beta HCG levels is not showing that much amount or quantity where we need to do some intervention. So such cases, these termed as pregnancy of unknown location. So these cases needs a further follow-up. So we can further evaluate a follow-up visit of that patient after 48 hours so that we can see that how the beta HCG level is going on. And if it still won't, we are unable to see at particular beta HCG level on follow-up even, then we can always arrange a scan to see the possibility of this ectopic pregnancy. Okay, Millie?
Yeah.
And whenever we are sending these patients home, we need to bring this in notice to our senior consultant, and also put all these things in the notes, and always warn the patients regarding the red flag signs of having this ruptured ectopic pregnancy. Okay?
Yeah, okay. Yeah, I will do.
So that whenever such kinds of whenever we are sending these patients having this pregnancy of unknown location diagnosis, they can be brought back to the hospital, and they should know all these red flag signs, and even we have to write all these things to the GP so that whenever she's having fainting, dizziness, or shoulder tip pain, they needs to come back to the patient. And you can always admit these patients at the same time if they are willing to get admitted. Okay.
I mean, she wasn't in that pain and kind of thing that I would have, you know, and it was so busy, we didn't have the beds anyway.
Okay.
Yeah, I don't think there was anything different I could do, really.
Yeah, but you did a very good thing that you arranged for the pregnancy test, and you also took a history and did the examination. But the thing, Millie, is that you always have to involve whenever there is a hectic routine and there is a chance of missing these patients, always to escalate it to the higher authorities, like talk to your consultant, always discuss these cases to your seniors, like the ST5, or even to your consultant, so that they can see and can tell you more regarding these kinds of cases. And you'll always have to arrange for the scan. I know that this has been a very seems like when you're actually doing it on the dealing with the patients on floor, this seems quite difficult even with such a difficult hectic routine. So we can also do it that I can talk to your supervisor, and we can you can reflect all the changes things which you thought that you have learned from this incident, and you write on this, and then we can arrange your meeting with your consultant so that you can discuss that how things would have gone and what have you done to prevent it in the future.
Yeah.
And And then we can also discuss that the way you're telling that there is a hectic routine. So we can always discuss your rota consultant or the rota coordinator to manage whenever such a condition arises, to so that they can be an extra help or the other people can be involved in such situations. Okay.
Yeah. Okay, doctor. Yeah.
Thank you.
Okay. Okay. So, right then. So, reflection. What is reflection and why we do the reflection? So, reflection is unless a bit of feedback on this first, which you've done. So, I mean, obviously, for again, other than UK trainings, obviously, this is something different. Reflection is not about teaching or about kind of giving feedback or that type. Reflection is something. Reflection is in simple words. I will say, just like, you know, when we're just sitting, like sitting free, doing nothing, cup of tea in our hand, we're just sitting, you know, and then just thinking. Reflection means thinking, you know, in the back on some event, what happened. You know, and then just thinking, yeah, that happened. You know, sometimes people say, I remember things afterwards, like I should have done that. I had that, you know, I was having that argument with that person, and you know, I remember things always after. I just remember, like, I should have said this, I should have said this, you know, I should have answered this. Actually, this is reflection. Reflection is when the event has passed, and then you sit, and then you think about what happened, what was happening actually, what I did. What actually I should have done or I could do. And then not only this, thinking up to here there, you know, I should have done, I always remember afterwards. No, then you need to then intentionally need to think about how I'm actually going to apply that in future then, that this doesn't happen. You know, if somebody in the argument is telling me off, I'm just going to give a really good answer back as well. So how I'm going to do that? So that plan needs to be in place as well. Okay. So in simple words, this is exactly what the reflection is. Okay. So reflection is one of the very important part of our revalidation here, appraisals and the assessment, and very important learning tool, and also kind of a part of safety and quality or clinical governance as well, to deliver safe care to the patients, because this encourages the practitioners to, because sometimes, yes, so this woman, just like she's feeling, you know, she was saying, like, she came in, she was just a little bit of pain and, you know, a bit of bleeding, and she was doing fine, she was stable, gave paracetamol, I sent her home, I booked scan, I didn't do beta HCG, and I, you know, didn't do the bimanual. I mean, if I would have done even, I don't think I would have done anything different. So if you think, actually, forget for the time being, yes, if she do beta HCG that night, and then the next beta HCG is going to be done in 48 hours. So missing beta HCG, but that going to make any difference that she came later on in the night by ruptured ectopic? Scan, yes, she did book the scan. So what actually is she right to say, I don't think I could have done anything different, I could do anything different? Yeah, that's what she's saying. So that's not reflection, because there is a lot she needs to learn. She can't do different, and she could do different. Okay, so the reflection is basically for the practitioners to think themselves and to think about, you know, what happened exactly, how I can't do, and again, it's a non-blaming, it's self-activity. You don't force anybody to reflect on it, but you know, the GMC and the part of the appraisals and the assessments, it has been made non-mandatory. The clinicians must include certain number of reflection notes on their practice to, you know, give that evidence that they actually have that, you know, they have developed the habit to do it, that they're doing it, because that is one of the, again, one of the skills and one of the tools which can actually prevent things from going wrong. So that's what this reflection and the reflection has come into place. So what basically happened? They just are like, this is clinicians' own, yeah? This is clinicians' willingness to learn from what happened in the practice. Being open enough to share the element of practice with other colleagues to discuss, yeah? That take that inhibition away as well by thinking, you know, if something has gone wrong, if I discuss with anybody, I might get penalized. No, people should be rather open to come and discuss a say. And sometimes it's not formal reflection. And it's very common here, again, like the junior colleagues, the midwives, consultants, between themselves, sometimes they just simply pick up the phone. Sometimes I just sitting and say, by the way, you know, I have this patient, blah, 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 and she has this, and I have planned this and blah, this. But wait, is there anything you guys would have done different than this? You know, so that doesn't, it's about to promote this culture that for you, the patient safety should be the priority. You should not think about if I ask somebody else or I ask the opinion for somebody else, I will be like, you know, low graded, thinking this consultant doesn't know anything. Oh, well, she doesn't know anything, or they'll just be speedy, or she doesn't know, that's why she's asking me. Or I have the feeling, well, if I discuss with anybody else, they will feel like they know more than me and I don't. No, nothing. And not the other side to think that either. It's very common practice. We all do all the time. And they may not be very complicated and silly things. They are good for us to, because when you're working, and when more and more you become senior, and particularly as a consultants, you're mostly working in isolation. Like, you know, you're the consultant, you have your training and whatever you're doing, your clinics, theaters, etc. Your own personal observation from others and learning opportunities actually have decreased quite a lot. And then with the busy schedule and everything, although yes, we keep ourselves well updated, but still we don't get as a consultant that much of learning opportunities as we could get as a trainees. And but that's where this culture is encouraged, that, you know, we do discuss these, have regular even consultant meetings as well, where we just simply discuss our patients with them, just for, you know, the answer may be no, yes, I think we all would have done this. Or somebody might just say, or sometime I have done something, I'm not quite sure, and thinking, what else do I do with this woman? And then somebody might just, you know, come with some better or something different, or, you know, sometimes we sometimes send email to some other experts, typical experts, maybe in that particular, they've done some research at the other end of the country. So that's what it's all about. So in reflection, basically, what there are 3-4 main, basically, the bullet points you need to discuss, okay? In this particular situation, it's not you who is talking most, it's the person who is reflection, who's doing the reflecting. That person is talking most. That person needs to come up with the plan. You will just be facilitating and adding and acknowledging, all right? So again, when you go in, don't take the name of your colleague in a questioning manner. Be confident, just call from the name, whatever the name was there, Jade Morley, whatever. Hi, Jade, you know, I'm Dr. Malik. And, you know, so I understand you have booked this session to reflect on one of your patients. So yeah, okay, so yeah, please tell me what that you know, what was that case, what exactly happened. And then let her tell you the details, which I did, yeah. Told this happened, I examined her, I sent this, and blah and blah. Now, after that description, basically, it didn't actually help me anything other than listening the story that happened. No, I'm not going to start straight away and ask, did you do pregnancy test? Did you do this or did you do this? No, all I'm going to ask her is to say, okay, so yeah, that happened. So you see, so oh, that's good. I'm glad that you were able to go and see the patient and that she has done really well and recovered well as well. So pretty good. So first I will ask, so what made you to feel that you should reflect on this? You know, do you think there is something different you could have done? Yeah. So encourage her now to think about from that point of view, that what that was. Because if she's reflecting, or even if not, and maybe consultant has said, maybe somebody else has said, and she still haven't recognized that why I'm reflecting on this case. So encourage her first to say, so yeah, it looks, yeah, okay, so that's what happens. So what do you think? Do you think there, you know, after your reflection, do you think there was anything different you could have done? And if she comes with this, she identifies certain things that, yes, I should have done the abdominal examination. I should have discussed with the registrar, because obviously any admission and even discharge, they need to be discussed with the registrar. And if she was busy, to give a ring to the consultant, because being ST1 or ST2, you're not supposed to admit or discharge the patient on your own anyway.
Yeah, so you will say that's the next step. Yes, I would have discussed, because if there was anything different, they could tell me. And then you can say, okay, so the next step is then to say, okay, so what you learned from it. And then you could tell me more in more detail, or simply when she said that, and I asked, okay, what do you think there was anything different you could have done? Yes, I mean, I know, we should do bimanual examination of these girls, and spectrum examination I could do, but I couldn't because. And if she herself tell the reason, then what the reason was, is I continued by saying, because that was really mad night that day, one of those nights when it was so busy, the bleep was going on and on all the time, and I was just rushing this, and the registrar was there, and I didn't have to eat. And well, then it's okay, we can then build up over there. But if she doesn't, then I will encourage you. That's well, could you think so? Okay, yeah, so I agree. Obviously, that's obviously this is your second year of training. I'm pretty sure you know that the patient should have had a bimanual examination, but obviously you failed to do that. So what do you think then? What happened that day? What would have made you to miss this? Yeah, because even tiredness, even not eating at proper time, we know this is one of the safety factors as well. If you haven't eaten and drinking properly, you're dehydrated, you're hungry, and you're so tired, you cannot focus, you cannot concentrate. And if you can't concentrate, then this type of mistakes you would be making. And the question here is not that would that have made any difference doing bimanual examination and doing this, and would that have made any difference? No, this is not the question. Again, it's not about that, yes, maybe on examination she may not have been tender and all that stuff, and we would have just sent the home after beta HCG to say, but did you give her the silent symptoms of a red flag? Did you check where she lives? Is there anybody you can bring her in? That bit. And then even we have given all this information, still she might have ended up having ruptured ectopic and come back. So it's not about this. It's also about developing and learning those skills and behavior. Okay, that what is important and we must do it. Okay, so encourage her first to tell you about all that which she says, and then again, before you actually add up anything, just encourage her to then tell, okay, so what you learned from it. Okay, so if he says yes, I feel I was lacking really. I couldn't focus and concentrate because I was so really tired. And yes, I could speak to the consultant, or I could do this one and this one. And then you can just add, okay, so I come more specific to this now. So she described the event and stuff. This happened, this happened. The next question goes, and what you feel, what could have you done different? She told you, I should have done this examination and stuff, and why you, how you feel, like why you missed that. And then she said, because I was tired, I was eating and all and that stuff. So then I would say, well, okay, yeah, that's really important. First of all, I will really appreciate that you, you realize that you should reflect on this case, because obviously that's only is again for safety and learning purposes. Reflection on any of these, for the cases, obviously always help us to retrospectively think and plan and then learn the things, and then what we have learned to apply that in our practice so that that doesn't happen again. So first acknowledge and appreciate her. And then you can say, yes, I'm in obs and gynae, yes, it's not unusual to be that busy all the time, and I can see, yes, certain days really go mad. But then these are actually the days when we are very busy and we don't get the time to eat and drink. That is the time we are most vulnerable to make mistakes, because if you're dehydrated, we're not eating well, we are so tired and trying to rush between so many patients, we cannot focus and concentrate really well. So that's why it's also very important that we, develop this skill as well to, keep ourselves calm in that stage and try to prioritize and organize our tasks. And if we are really caught up with some important task in the patient, it's okay to tell the nurses or the midwives to say that I am, busy with this some urgent and emergency situation or case, so I will not be able to quite quickly come and see the other patient. They may consider to speak to the registrar or even to the consultant. It's absolutely okay to do that. All right. And then the next important point is to tell her that it's very important then that we also keep an idea about the limitations of our role and training as well, and that we shouldn't be admitting or discharging, sending any homes before actually discussing with the registrar or the consultant. So how you feel about, like, if you would have actually discussed that with your ST5 that day, do you feel that could make a difference? So then the answer comes when she was really busy. She was in theater as well, and that's why I couldn't know. She was all right. Yeah, okay. So in that case, I mean, if that happened, then obviously, you can always ring to the consultant. So we are actually telling her the path we are as well. Yeah, so we are kind of making her to learn what the next pathway is. If the registrar is not there, okay, ring the consultant. And then, then go to the another aspect which she has identified as a problem, that I was not able to eat and drink. So then it says, so probably it's very important as well then to recognize, yes, sometimes it goes so busy, so one after the other, one after the other. Then we just keep waiting that I will eat and drink when I finish the patients. That's not going to happen. That will never happen. So it's important that you do try to take some regular small, break to eat and drink. And it's okay to tell the midwives that even to your, ST5, if it's going really mad, then it's okay to tell them, just to say, like, I need 10 minutes just to go in there and eat and drink, and then I'm coming back. So as long as they know, obviously they can, they know then, okay, not to call you for the time being, to ring to the registrar straight or even to the consultant. So tell her that way to do it. And then, then you can ask, okay, so how you feel then, how you're going to apply that. The next one is, how has this influenced your practice? Like, again, or what have you learned from it and how you're going to apply it? Yes, it's very important that how you're going to apply that in your practice. Yeah, so we want to basically listen from her in simple words again, then to say, yes, the first thing is I want to make sure, I would like make sure in future that I always ring and discuss before I discharge any patients. And if yes, I'm busy, basically to repeat things which we have tell her, that then I take proper time to eat and drink, and if I can't, then let the registrar know, consultant ring, and do the biomanual examination. So not to compromise the care of any patient just because we're too busy. So the patient that you are seeing, that you must fully focus on that patient. That patient should be the priority, unless you have to leave the patient and rush to attend some other emergency. All right. So that's what it is. And it's again not very uncommon here, again, the people who are working here, that sometimes the people, and particularly the midwives and the nurses, when they're doing something, I mean, even you want to talk something maybe very simple, you want to ask what it is, or they might be just writing the notes and they will say, sorry, just excuse me, let me just finish this first. I mean, you might just be asking about, okay, where can I find whatever, the cannulas or whatever, and they will not. They might just say, let me just finish this. And this is how it should be. If you're focusing, you need to focus and concentrate on some task. You must tell others to hold on or wait, let me finish this first. So these are again just like to reduce the risk of any harm to the patients. Quick question.
Dr. B, I have a question. Like in this scenario, she kept saying that I wouldn't have done anything different. I wouldn't have done anything different. If that's the case, that we can clearly see that something should have been done differently, but our candidate who is reflecting is not showing any insight into this. I mean, more aware than this scenario. What should we do then?
Yeah, so that simply means that she actually does not understand the purpose of reflection, why we do the reflection. So we need to then, in that case, help her to understand that, that it is not just particularly about that one patient which you have seen, that whether it could have done any difference or not. So even if she has missed, it's not about the outcome, what we would have done. We know in the ladder of process, which is in the praise, the process is obviously there's a difference between the clinical management and then the process. And the processes are in place to make sure that we don't do something wrong, so to avoid the harm. So the process is, for a junior doctor, that they go, so they need guidelines, they are process, right? So she goes, so process is she goes to examine that woman, and when she goes, she follow what the guideline or her training says. And the training says, okay, just first of all, anybody in childbearing age coming with a low abdominal pain, do pregnancy test. If that is negative, and it's early weeks, 6-7 weeks, you have to exclude ectopic pregnancy, right? So, and how to exclude them? So the exclusion is obviously from the sign and symptoms, from the history, what there is. Then you do abdominal examination for any tenderness, biomanual examination for any cervical motion tenderness, any tenderness, pulse blood pressure, all that, history of any pain, shoulder tip pain. And so that is part of the process. And then the next part of the process is that you give a ring to your, whatever the assessment is, then you give a ring to your registrar to say that I have this patient, this is blah, 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 this. And then, yes, you can give your plan, which you think is like, she's okay, I have done the beta HCG, I have booked her scan for, which is for, on this date and time, obviously we can book these early pregnancy assessment plans straight away. We can even give them a date straight away to say in 3 days or 4 days, come back. Or if not, if it's in the night, we say this first thing in the morning, the nurses will book your scan and send you. Meanwhile, if you develop these symptoms, you must immediately tell us, and it's important somebody is there with you, right? If she's like really mild and we have to send. In this case, what has happened, the things, not about the management, clinical management point of view, yes, maybe nothing would have been different, right? She would have spoken to the registrar, and the registrar might have said, yes, it's okay, give her these instructions and send her home, or calling to the consultant. But what wrong is gone here, that she has not followed, she has not understood the importance of that, because it could be something other way around as well. This time, yes, it didn't cause any harm or anything like that. What if she was alone at home, that woman, when she goes home, and she was alone, and she suddenly has a rupture and she collapses, and there is nobody around to actually ring the ambulance? All right, so we don't want this trainee to just think, well, take the casual behavior to say, even if she missed something in the process, it's fine, or it doesn't know. We want them to realize, consciously learn this, that these processes are there for some reason. We must stick to these processes. We must eat and drink at proper time so that we can focus and concentrate. She missed these steps in the process because she was not concentrating, because she was hungry, she was tired. Yeah. Yeah, so that's what you need to make her understand. Okay, something teaching on the discharge letter is something quite, it comes quite kind of fairly regular as well. Operation sheet, no, operation sheet is okay, even if it's operation sheet, we will have a discharge letter later on, I think. Okay, so operation notes, sometime somebody has written, this is the total operation note. So how the typical is, in some units, here mostly, rather most of the units, there are templates already. Okay, so there are printed templates where you just literally fill in the information, and those templates are there again to make sure that there is a standard documentation being done, and the important things which should be the part of that documentation, they're not missed. Okay, so the standard, and if even it's not given over there, and you might be the person actually as a consultant to basically make that template. So what is important to be included in that template? So yes, so it can be two sides or the same side. The most, the most information which needs to be obviously patient's name, date of birth, and hospital number. And they are important for the identification of the number, right? And then if it's an operation note, then you see the name of the surgeon, full name, whatever that is. Then consultant, give the title as well, if it's consultant or it's MSD or whatever. And then, the type of name of the operation should be first here. So the name of the operation or name of the procedure, okay, I've written down. It should be ideally first. So name of the procedure, and then indication why we needed to do that. Then type of anesthesia, what the anesthesia was used, name of the anesthetist as well, and whether it's a consultant or ST5. And I mean, common sense, very simple reasons for these ones. We want to have this like in case if we have some complication for this patient, or in future, like the patient is discharged all well and home and they have some problems, and we need to get that information then back from the consultant or something. Unless we have actually made this proper documentation, we won't be able to get that information. Who was the person? Simple, yeah. Indication, then of the procedure, and then you write the notes. So brief notes about the operation, what happened. Small, I mean, this particular procedure was very simple. Obviously, suction evacuation, motor one, you would say suction evacuation done. No complications, no problems, and the total blood loss, what there was, you would write on that one. And if any blood transfusion has been given, histology, what is the post-op plan? That should be clear again, plus blood pressure, and particularly if you want any particular way of monitoring, you know, if the patient has bled quite heavily and you want, for the first, you know, few hours, you want maybe hourly check, or, you know, you need to tell them. Write that down as well. And then if you want to repeat blood sample, maybe in the evening after 4 hours at tomorrow, it needs to be there as well. And senior doctor review prior to discharge. Maybe there has been some preparation or something that happened here. So between the name of the procedure, indication here, and next to blood transfusion thing, in between should be operation notes, yeah? Briefly, like, you know, this suction evacuation done. If there was any complication, mention that one briefly again. If not, a straightforward procedure, no complications, or, you know, just write down that one, and then so this is how it should look like. Refer to regional gestation trophoblastic disease center. Okay, simple. I don't think that is a problem for any of you. I think all over the world you do the same practice. So discharge summary, how we write down the discharge letter. Discharge letter again is usually the unit head letterhead. So on the top here will be like the name of the hospital, you know, whatever that his hospital is, and then on one side, on this side is the details of the GP, the person who you're sending to, and this side is the name of your own unit in the hospital. Okay, so now look at what is important to be. Yeah, so the name of GP should be full name and full address, and then on the other side you need to have the hospital name, department, and then inquiries too. This is very important, like some secretary or somebody, because if GP is not clear about something, it's very important that he knows which person and on which number he needs to contact. Okay, so that's why the persons too on the phone number, that is important. Then comes the patient details for identification for the GP as well, and for them as well. Okay, so the patient details, again, those 3-4 main identifiers which are used for the patient, obviously name of the patient, date of birth, and hospital or NHS number of the patient. Yeah, so that will be there. And then down there will be, only if my slide like to move down. Okay, so after all those identification and stuff, then obviously you will write down the admission. So you need to basically know what the purpose of the discharge letter is. You are going to give a snap of a scan, brief story of the patient in the hospital. Okay, either your patient attended or what happened. So simply then that makes sense. It should be date, time of admission, then type of admission, whether there was like we admitted through the clinic, like she came for antenatal clinic and her blood pressure was high and there was a proteinuria, so we entered. So through antenatal clinic, or she presented in an emergency. You know, she came to visit labor ward, but she rang us and telling us she has some bleeding, or she's like, you know, feeling really dizzy or whatever, or she's having severe pain, a headache, and she's having blurring of vision. That is an emergency admission, yeah. Or planned, maybe, you know, some lady coming for elective cesarean section, or we have already planned we will be admitting this patient at 36 weeks. So, and that is again important, obviously, for the GP to understand as well what basically this patient went through. And source of admission, whether it were from A&E, ICU, sometimes it may be that patient initially I mean, it's not obviously only the labor ward and the obstetric discharge. It can be gynae as well. So it could be the source of admission from A&E or ICU. I mean, A&E, she came in the A&E. She was like, say, she was collapsed and she had whatever necrosis and sepsis and all that. And from there, she was so serious, we had to actually transfer her to straight to ICU. So we need to tell. So ward admission is different. Okay, so even when the patient is transferred from A&E to ward, then the ward has to kind of make admission in their own regard. Okay, so there will be admission from A&E or from ICU, or the patient presented straight from the home. Duration of hospital stay was 4 days. Date of discharge, you tell what that was, and then okay, so then you go to this. I mean, I try to take the information away, but please, if you can see anything, don't focus on it. So basically, then you briefly tell what the diagnosis was. Yeah. So why she came in? Yeah. So you came with the pain in. I mean, that's not gynae. That's just somewhere anything. So then we write down. Yeah. She presented with abdominal pain, and the diagnosis was, say, we keep 2 hours. Let's say. So we will say like what the ectopic pregnancy suspected was ectopic, and then if she had any comorbidities like she was diabetic, antihypertensive, or anything, and the brief detail now here. I mean, you don't have to particularly write down history. You can just say presenting complaint, usually is the word used there. So you can say 3-day history of, or 6 weeks, or, 6 weeks amenorrhea, pregnancy test positive, acute abdominal pain, and shoulder tip pain. And we can say blood pressure if she was hypertensive or anything like that, we can write down. And then the examination, you can then write down, she was hypertensive, tenderness, atinexa, this and this. And then the next one will be, I won't be bothered about weight here because that is about the child, that's why, but in ours weight is not there. Then next will be investigations then. What investigations we did. Investigations is like whatever your results are. Beta ECG was this and the scan was this. And if there was no time actually to do investigations, you can just simply say, we would have obviously sent something which would have come after. So still you can write a full blood count group and say what's this. Group was this and beta HCG was this. And then you will say the next one will be below the investigation is like the management, what we did. Yeah. So we can say, so if we did, we'll say laparoscopic right self-injectomy. If there was any complication happen, like she had a heavy bleeding and we gave her any blood transfusion, then that needs to be included to say, the ruptured ectopic, blood loss, estimated whatever the blood loss was, we need to say that blood loss, 2 blood transfusion given, this given, this given. We need to include that one. And then say post-op hemoglobin this. The hemoglobin at the time of discharge was this. And if we want then to GP to actually do something, repeat that page something later on, we will give that instruction to the GP. So after that, what during the operation happened and what we have done. If it is straightforward, you can say, straightforward suction evacuation. Say, yeah, if it was straightforward suction evacuation, rhesus positive. That means we didn't need to give any NTD or something. All right, a conditional discharge, well, stable discharge to home. And follow-up plan, pregnancy test in 3 weeks at home. Okay, in case of ectopic pregnancy, if we come back to that one, she has a hemorrhage and all that story. In this woman, obviously will be the follow-up will be, we want to see maybe back after, 6 weeks. Yeah, so follow-up arranged by us will be 6 weeks. And any instructions for the GP will be like, say, if we have arranged beta ECG in the hospital, we want to do beta ECG for next so many weeks, then we will write on here, follow-up, in our follow-up, beta ECG in OPD or early pregnancy assessment unit weekly, and the appointments are made. Right, so we need to then tell as well, we have made those appointments on these dates. Instructions for the GP will be, please repeat hemoglobin in 1 week. And then do accordingly. Or if there is any other medication, we want to say we have given these, and then drugs on discharge. Okay, that will be the next thing then after investigation, the stuff. Drugs on discharge. So if we are giving her, say, paracetamol, whatever, Panadol, or whatever we are giving, you just write down basically this medicine, this dose 3 times a day for 3 days, And if you want GP to actually continue with that, you know, in our instructions to GP, we will add that as well. So say, for example, she was hypertensive, preeclampsia, and we have started on, you know, on labetalol. So we are sending our follow-up plan will be saying, you know, daily blood pressure check by the community midwife for first 1 week, and then maybe we can say weekly. To the instruction to the GP, we will request to say, please review the blood pressure in 1 week, and then, you know, titrate the blood pressure and the dose of the labetalol accordingly. So we will leave that to the GP to manage that in the community. Okay, so these are the important headings and how they should be followed. All right. Okay, so medication changes if they are taking already. I mean, that will come under the medication. I have discussed this already. TTO medication, that's the one which we're giving you. Either you call it TTO medication on discharge usually. You know, that's one is like the Ceralide paracetamol 3 times a day, or labetalol 200 milligram 3 times a day. This and blood pressure follow up by the midwife daily, and then for the GP. Actions for GP, yeah, or instructions or actions for GP. You will have all that. If you want him to repeat any blood test, if you want him to follow, you might have sent the blood test from here and the result is not back, then you can say, please chase up this blood sent on this date. And then if you want him to tailor any of the medication, that will be here. Then additional follow-up action like that is usually are the follow-up by the team. That is like outpatient on this date. And yes, information given to the patient and completed by the name of the person and whatever. I'm so sorry, there are few information there. Okay. Is that clear now about the discharge summary? Any question?
No, thank you.
Okay, so there was one recall which has appeared, I think, a couple of times about enhanced recovery program. And then also, I think it goes by saying if you have to, you know, like make and put enhanced recovery program for your trust, for your team, how will you proceed? So that will be a bit long one, so I can't do it today. So what I can do, you all have that previous, because that is again kind of more lecture based type of topic. So if you, I think you all have that last recording, yeah?
Ma'am, the recording you send us actually has only half the scenario. I think that time you took it in 2 sessions. So only the first session recording we have got. This ERAS and everything we haven't got.
You're right. About to clinical governance, that's right. Okay, I will send the second one as well and this one as well. Okay. Because the difference from others in this one will be we took the scenario of 39 weeks and did in a bit more applied manner. The rest is same, the topics. So otherwise I'll do that like in next session if you guys feel like we want to go over it. Okay. And structured discussion, if you can put them into, I know some of you have sent me, but they are at different places. So whoever has posted already those, you know, can you please send them to into group, like on November group and also in July group, one of those. Instead, you know, some of you have sent individually to me. So please just put them all together in the group so I can put them together for the session. All right. Okay. Any question before I close for today?
So operation, ma'am, just wanted to ask that for the discharge letters, we have 3 copies. One we keep it with the notes, one to the GP and one with the patient. How about the consent forms? How many copies are there?
Okay, so the consent form, one copy, the original, stays in the patient notes. And the in old days, obviously, no, it's electronic. So we have the consent form obviously electronically. We print one copy and give it to the patient. And one obviously stays in the notes. The discharge letter, same way. We basically, yes, so you will print to, one will stay obviously part of the notes, and you will print out 2 copies, give one to the patient, send one to the GP. Yeah, anything else?
If the patient has not made up her mind in consent while we are taking consent for cesarean or hysterectomy, so we can always say that we always say like whenever you have made up your mind, put signature on that. So we also do a check on the operation notes. When the list is already planned, so we also have to see the consent form, the consent, and the signature of the patient. I just wanted to ask that if the patient wanted to add something in that consent paper, then do we have to make a new consent form, or we can add it down somewhere?
So it can be done both ways. So if she changes the mind and like it's the day before or something, then you have the time. Obviously, you can just write down a new consent form and cancel the previous one. You will then cross the previous one. You will write down cancelled on it, and you will put the signatures and the date. And then you can have a new consent, and obviously make sure that you change that procedure on the theatre list. You inform the consultant and you inform the theatre team and the anesthetist as well. Now, if that is like just before the morning, when we see in the morning of the when we're going for a theatre, and the morning round is like about hardly half an hour, we go around, just make sure with their consent to make sure they're happy to go ahead with that same thing. At that stage, obviously, there's not enough time to basically sit down with them and then do the whole consent again. Then you can just write down add to the same consent form. So you will say, okay, so we're going to add. So you add, so say she was for hysterectomy before. Now she wants to have a bilateral salpingo-oophorectomy as well. So initially she has been consented the name of the procedure, removal of the womb, total abdominal hysterectomy. And obviously that will say with preservation of ovaries. Now you will cross that one, push your signatures, date and time, and make the patient on the preservation one. Instead, you will write down with, and removal of both ovaries and the tears requested by the patient. And then you write down your name, date, and you ask the patient to signature date.
Thank you, ma'am.
Okay, so we close it here then, and I'll send you both of these sections. Bye now.
Bye, ma'am. Good night.
Thank you. Bye.
Thank you.